So now we are beginning with ENT. So ENT is a subject which I consider as a short subject because the questions, the amount of questions that you get from this subject are not many. You get around 4 to 5 with INI or NEET. In NEET, the proportion increases slightly, but it's very high yield, very scoring. So they ask basic questions. This is one subject where they don't want to test a lot of fancy things. They stick to basics. So that's what we'll be focusing on. Start from basics and do a few extra edge points here and there. So let's start off with the topic of ear. That is almost 2/3, even though it's 1/3 of the name, it's 2/3 of the length. So that's what the main focus is. Then nose, paranasal sinus, and then throat, which includes pharynx, larynx, and then we'll talk about a few miscellaneous points, for example, tracheostomy, airway management, those will be covered in the end. So let's start off with ear. The most important part of ear is going to be the anatomy. They love asking the nerve supply of the external ear. So this is an image from Dhingra and they love this. So this is what you have to first of all remember. What are the nerves that supply the external ear except? If they ask you that question, that's easiest. Remember, no, go. You will see that there is great auricular nerve that supplies, lesser occipital that supplies. So that's why one obvious option becomes great occipital, which does not supply. So first things first, remember no go, right? No great occipital. So now what does supply? So obviously, as the name suggests, great auricular nerve. Great part of the ear is supplied by this, and it is true to the name. You can see majority of the ear is getting its supply from great auricular, lesser from lesser occipital, and then you have this inner part here which is supplied by the cranial nerves. So now which cranial nerves are supplying? Mainly 3. So we have cranial nerve 7, we have 10, and you can see the auriculotemporal nerve here, which is V3. So auriculotemporal nerve, as the name has A and R, remember, also supplies the anterior wall and the roof of the external auditory canal. So AR supplies external part and also supplies anterior wall and roof. So the remaining is supplied by 7 and 10. So the posterior wall and the floor of ESC are going to get its supply from 7th and 10th. Here itself, remember, the named branch of 10th that supplies is going to be the Arnold's nerve. Very, very important. Okay, so Arnold's nerve is the named branch of 10th nerve that supplies, right? So this is what we have learned as far as the nerve supply is concerned. You remember great auricular nerve we had done in surgery, runs along with external jugular vein, comes to the lobule, supplies great part of the ear. It's C2, C3, and it is the only part of the face sensation that's not supplied by trigeminal. Remember, shaving angle. So that's the great auricular nerve C2, C3 that we are seeing here. Okay, so this is what we need to learn about the nerve supply. Let's add on to that. What about the middle ear? So middle ear is getting its supply from the 9th cranial nerve. So that makes it 4 cranial nerves that supply the ear. V3, 7, 10 and 9. So 9th glossopharyngeal nerve forms this plexus which is called as the Jacobson's nerve. So it forms the tympanic plexus because of the Jacobson's nerve which is supplying the middle ear. So together, so middle ear supplied by 9th cranial nerve. Alright, so with this we can learn something, that there can be referred pain, right? So no matter where the pain is, it can come to the ear thanks to these cranial nerves which are supplying the ear. So let's say somebody has tonsillitis and they have otalgia. Which nerve is it because of? This is a PYQ. It's because of the 9th cranial nerve, right? Because 9th cranial nerve runs in the tonsillar bed. So that's where the referred pain comes from. Larynx, pharynx, 10th cranial nerve, so that can get supplied to the ear. And face, don't make the mistake of saying facial nerve, because facial nerve is motor to the face. What is sensory to the face which will refer has to be V3. So this is one place where students will make a mistake. They'll think of facial nerve, face. No, not that simple, right? Who is the sensory to the face? It's V3. So auriculotemporal will refer to the ear, right? Let's learn the inner ear anatomy now. So keep it simple. The parts which are superior and lateral semicircular canal and utricle upper hai. Here remember upper. Don't remember sir for superior. You will go wrong. So jo upper hai, that is getting its supply from superior vestibular nerve, whereas saccule and posterior, whatever is left, is getting its supply from inferior vestibular nerve. Cochlea obviously will get its supply from cochlear nerve. So no need to write that. So that becomes your eighth cranial nerve, vestibulocochlear nerve. It's the sensory nerve, right? So we have superior, upper, superior and lateral semicircular canal, remaining are inferior. So that completes all of the nerve supply of the ear. Let's do some parts of the external ear here. So what are the important parts? So you know this curved part here is the helix. Here there is an atavistic feature. It's a remnant, you know, which is a Darwin's tubercle, very common. So this Darwin's tubercle, no significance. It is an atavistic feature. You know, with evolution, we have gotten rid of it. Some people are less evolved, so they may have it. Okay, so that is Darwin's tubercle. Then what do you see here near the root of the helix? Root of helix means where the helix curve begins, right? So that is where there may be a sinus opening, which is preauricular sinus, and that happens because of inadequate fusion. How is the external ear forming? So this is forming by hillocks of his, right? So when these hillocks of his, which are basically your first and second pharyngeal arches, don't fuse properly, they may leave behind this preauricular sinus. Okay, so it's because of inadequate fusion. Rest of the ear embryology we have learned, right, in anatomy. Do you remember the external auditory canal is getting its supply from the cleft, that's the first cleft, the middle ear, the additus ad antrum and the mastoid. All of these are coming from the first pouch, right? And tympanic membrane, all cleft, arch and pouch. So that's what we have done already in anat. So that's a quick refresher. So this is what is about the pinna, right? So we have helix, this is root of helix. Then you can see this part here. So this is the depression, which is the concha, right? You can feel it in yourself. So that's the concha. So uske just upar is the simba concha, this curvature. So simba concha, they say, just deep to it is the mastoid antrum. So this is the landmark for mastoid antrum, right? So this is the hidden way to reach the mastoid antrum. Nobody uses this way. Okay, so this is what you can see. Then what else? This is lobule. What's the significance of lobule and what is the significance of this part here, that is incisura terminalis? So the part that I have shaded, incisura terminalis and lobule. So your external ear pinna, it is one big piece of yellow elastic cartilage. The only places where this cartilage is lacking. So incisura, lobule, feel the lobule, it's soft, right? There's no cartilage here. The significance for incisura terminalis is we can give an incision here because there's no cartilage, and that is called as Lempert's endoral incision. So this is how you can reach, you can access the ear. The most common way we reach the ear is, understand this right here, right now, the mastoid, right? We have the mastoid behind the ear, so it's posterior to the ear. So if I dig deep into the mastoid antrum, which are nothing but air cells, and I take a turn anteriorly, I'm going to reach the middle ear, right? So that's the approach that's usually taken. But in children, I cannot take that because remember one lateral point here, that the mastoid tip, right, does not form till 2 years. So it only forms after 2 years. So before 2 years, it's not safe there because you might just injure the cranial nerves. So that's why before 2 years, one approach is go through the external auditory canal, and that is Lempert's endoral incision, which is given at incisura terminalis. And through that, you learn that incisura terminalis does not have cartilage, right? So that's all about the anatomy of the external ear. What all did we learn? Darwin's tubercle, preauricular sinus is a lack of fusion, two parts which does not have cartilage, and that simba concha के नीचे mastoid antrum है. Okay, so this is about the anatomy. Let's go inside external auditory canal. So when we talk about external auditory canal, it's 24 millimeters. The outer 1/3 is cartilage, right? It's continuing with the cartilage, and inner 2/3 is bony. So that makes sense. Now, the narrowest part of external auditory canal is where? So remember, it is 5 mm lateral to the tympanic membrane. So it's not at tympanic membrane, just 5 mm lateral, and that's where foreign bodies can get impacted, right? So if you want to know the significance, it's obvious. Foreign bodies can get impacted here. So cartilaginous part has these fissures or these communications which are called fissures of Santorini. कैसे याद रखेंगे? S and S. So outer part में, which is cartilage, communicates with pinna. So Santorini hai. And these are what are communications with the parotid, right? So they are communicating with parotid. Whereas inner two-third we have Hushke foramina, which communicate with the skull base. So they communicate. So what is the bony plate? That is tegmen tympani, right? So that's the roof of the ear. That is above which we have the temporal lobe. So this is where if there are fissures, my ear infection will extend into the brain through the tegmen tympani, through these foramina of Hushke. The good thing is they close by 4 years. But in children, if they have an external ear infection, it can actually go to the brain. So that's the danger part. So that's why you'll remember Hushke. बच्चों को बोलेंगे hush. Right? So Hushke is for kids less than 4 years. We have to be careful of their ear infection. Fine. So what did we do? So cartilage, Santorini, parotid. Children, hush will go into the brain. Okay. So the next question is, in which direction will you do syringing if you want to clean the ear? So here you remember, first of all, in which direction will you pull the pinna? It's going to be upward, outward and backward. Okay. Upward, outward and backward you will pull on the pinna, and then the question will be, where is the jet directed? So it is directed supero-posteriorly. Okay, so supero-posteriorly you will direct the jet. Okay, so superior is the roof, posterior is posterior. So how I remember this is, one part I have taken from here and one part I have taken from here. Okay, so supero-posteriorly you will direct the jet. And if they give you this history that somebody while cleaning the ear underwent syncope, bradycardia ho gaya, which is the nerve? Vagal stimulation, right? So we just saw that vagus 7th and 10th were supplying posterior wall and the floor of ESC. So that's why it can get stimulated, and you know when vagal stimulation happens, parasympathetic stimulation, heart slows down. So you may have bradycardia resulting in syncope. So that's Arnold's nerve. On similar lines, what is Hitzelberger sign? So any injury to 7th nerve, particularly when it happens secondary to a vestibular schwannoma, that can result in loss of sensation in the ESC. Which part of ESC you will tell? Posterior wall and floor, right? So just remember, anterior roof is not 7th and 10th. That's auriculotemporal. So posterior wall and floor of ESC ka loss of sensation because of vestibular schwannoma, because of 7th nerve involvement by that tumor, that is Hitzelberger sign. So these are just lateral questions that you can solve through this nerve supply, right? So this is about the external ear, external auditory canal. Now, where have we reached? We have reached the tympanic membrane. But before that, let's finish all the diseases of the external ear right here, right now. So what is this? This is what is called as a boxer's ear. Basically, any trauma to cartilage. See, cartilage is not going to heal itself. A fracture of a bone may reduce, but a cartilage will undergo necrosis. So what you have to do, if there is any trauma to the cartilage, before it undergoes necrosis, drain that hematoma, because the pressure will cause it to get necrosed. So that is why any hematoma in the pinna, right, or any cartilage for that matter, must be drained, right? Otherwise, what will happen? You will have this deformity where the cartilage undergoes necrosis. That's called boxer's ear or cauliflower ear. So this is a complication of hematoma in the pinna. Very, very important. Next one, when we were giving our exams, this was a question which was 100% asked. ENT had 4 to 5 questions in names, out of which one we already knew is going to be malignant otitis externa. That's how commonly this is asked. Okay, so what will be the buzzword? The buzzword will be a diabetic patient, poorly controlled diabetic patient comes to you and says, doctor, I'm having this diffuse pus coming from my ear, and what is dangerous is this granulation tissue, black necrotic tissue that's coming. So looking at this, even the patient is scared, right? The doctor, do I have a malignancy? Your doctor here said yes, and they named it malignant otitis externa. But is it really a malignancy? It is not. It's a misnomer. It just looks dangerous, right? So this is malignant otitis externa, which is actually an infection by Pseudomonas. So it's Pseudomonas which is destroying the external ear, resulting in pus and granulation tissue. So this is what we need to remember, diabetes being the buzzword. So there are two tests here. We can do technetium 99M scan. You know, this will take up anything where you have inflammation. So technetium 99M is more of a diagnostic tool, whereas to see the follow-up on treatment, whether the patient is responding or not, we have gallium scan to assess the response. So this is to assess response to treatment, and you can also see the ESR, which will decrease with treatment. So obviously, what is the treatment? Anti-pseudomonal antibiotics we have to give, namely 2 third generation cephalosporins. What are they? Cefoperazone and ceftazidime, right? So this is what we are going to give these patients of malignant otitis externa. Rarely it can go and affect the other cranial nerves, right? By spreading the infection, commonly 7th cranial nerve can also be affected here. So diabetic, pus, granulation tissue, malignant otitis externa. Next, we have this collection of squamous epithelium which is collecting in the ear. This is what is called as keratosis obturans. So what is keratosis obturans? This is a collection of squamous epithelium. So this is squamous epithelial debris or keratin which is collecting in the ear, just a spotter. Then look at this. Can you see these bony outgrowths which are sessile? They are not having a narrow stalk. So these are sessile exostosis. So what are these? These are also called as surfer's ear. So these are sessile exostosis, or what we call as osteochondromas in the external auditory canal, and this happens more in surfers because of the high pressure jet going into the ear, right? So this is surfer's ear. Don't mistake this with swimmer's ear. So swimmer's ear kya hota hai? This is what is generalized otitis externa. So generalized otitis externa, also called as diffuse otitis externa. So this is where, again, the most common cause here also is Pseudomonas. So this is where you have an infection. The hallmark here is pain, exquisite pain, very, very tender to touch. They will not allow you to touch the pinna. That's how painful it is. So very painful, very tender, caused by Pseudomonas. Again, the treatment is antibiotics. So this is where you have a diffuse inflammation, happens more in swimmers. Okay, so surfer, high pressure, exostosis. Swimmers, infection of the external ear. Then look at this. Looks like a wet newspaper, isn't it? So very rightly called as a wet newspaper sign. The hallmark that all of you are noticing is black. When you see black, which aspergillus comes to your mind? Aspergillus niger. So this is what is otomycosis, external ear infection by fungus, Aspergillus niger. Hence, you have the black pigment that it produces. So these are a few external ear conditions that we need to know about. Now we have reached the tympanic membrane. So let's talk about tympanic membrane. So this is what it looks like from the external examination. So we have two parts, right? You have the pars flaccida and we have the big pars tensa. So the pars tensa is made up of these three layers in the pars tensa. So you have epithelial layer, you have the fibrous layer, and you have the mucosal layer. Whereas pars flaccida, why is it flaccid? Because it does not have the thick fibrous layer. So F ke paas F nahi hai. That's how you can remember. So pars flaccida, it is also called as shrapnel's membrane. So this is where F does not have F. That's all you have to remember. So this is about pars flaccida, which is the upper part, right? And this is what will be the upper part of middle ear called epitympanum. The part of middle ear against this big pars tensa is going to be mesotympanum, and uske niche hoga hypotympanum. So let's discuss that first. Epi, meso, hypo. So can I say epitympanum upper part hai against pars flaccida, meso is against pars tensa, the big part, and then we have hypotympanum, which is below it, the smallest part. Okay, the epitympanum contains this space which is called as Prusac space. Okay, so this is what contains the Prusac space, and here there is a bone, the roof of the ear, which is called as scutum. What is the significance of this? The significance is that when we have retraction of the tympanic membrane, let's say the eustachian tube is blocked, I have a bad cold right now. My eustachian tube is blocked, means I cannot hear properly, right? So what happens when our eustachian tube is not able to balance the pressure of the ear and rest of the pharynx? That now my tympanic membrane, because of a negative pressure comes in, gets retracted. So what can that result in? That can result in the skin of the ear coming inside, and that is what we call as cholesteatoma. Skin in the wrong place. I have squamous debris in the middle ear. So do you understand that the first part that this will go into is going to be epitympanum or scutum? So Prusac space is the space where earliest cholesteatoma forms, and scutum, that's why it's the first bone to show erosion if there is a cholesteatoma. So I have reached cholesteatoma topic, but just so that you understand the significance of this epitympanum. And this cholesteatoma is what I call as primary cholesteatoma because of retracted tympanic membrane. Did you understand this? So tympanic membrane retract hoga, upar se something is coming inside. So that is Prusac space, scutum. Okay. Mesotympanum, hypotympanum. Let's do some numbers now. So here you will remember 6, 2 and 4. Epitympanum, pretty wide, 6 mm. Mesotympanum, narrowest part, 2 mm. Hypotympanum, in between. So 6 is 2 plus 4, right? So 6 is 2 plus 4. So this is what we need to remember. Hypotympanum is the smallest part in area, right? So narrowest part, mesotympanum, smallest part, hypotympanum, right? Widest, all the questions, everything in epitympanum, scutum, Prusac space. Now let's do some questions on more numbers. So this tympanic membrane, total surface area actually is 90 mm square, but they say that the effective vibratory area is only 55. That works well for us because the angle of the tympanic membrane is 55. So that's the only number I choose to remember. 55 effective vibratory area, 55 degrees. So now let's see the contribution of this tympanic membrane on hearing. It is very, very important. So what the tympanic membrane does is, there is a ratio, right? So imagine this is the size of tympanic membrane. It is going to give the sound to malleus, incus, stapes, which is sitting on the oval window. So the ratio of the size of the stapes to the tympanic membrane is called as the areal ratio. So that's 17. Then we have the liver ratio. Liver ratio is what are the two ossicles. So this is what is the difference in the size between handle of malleus and the long process of incus. So the difference in the ratio of them is what is the liver ratio. 1.3. So the total, the multiplication of 17 into 1.3 is what is the total amplification that happens because the sound goes through conductive pathway, which is tympanic, malleus, incus, stapes, oval window. So this pathway offers us this amplification of 22 times 17 into 1.3. Another advantage is phase difference between oval window and round window. Now understand, if this is oval window, this is round window. Oval window is getting sound through the conductive pathway, right? This is where stapes is sitting. So conductive pathway is always faster. So here the sound wave reaches faster, whereas here it comes in later, right? So there is a difference in the phase by which basically the sound reaches here quickly. Here it is slowly coming, right? So basically what you will have at oval window is a phase of compression, while the round window is still in a phase of rarefaction, right? Sound wave has two phases, if you remember, compression, rarefaction. So this phase difference allows for an extra hearing power of 4 decibels. So that adds on again 4 decibels to your hearing. That is very, very important. Okay, so this is what is very important, and these 4 decibels you get when the tympanic membrane is intact, isn't it? Only then can this phase difference exist. And this significance I will tell you in some time, that what does tympanic membrane intact give you? It gives you that additional 4 decibel valuation. Okay, so this is all about the sound dynamics. This has never been tested really, but just for you, your understanding. Now let's get to this picture. पास फ्लैसिडा हो गया, पार्स टेंसा हो गया. What can you see through the tympanic membrane? The major structure is always going to be handle of malleus. One thing to know, what is anterior posterior? So the anterior malleolar fold is always going to be shorter than the posterior malleolar fold. So that's how I know what is anterior, what is posterior. The other thing that's always going to help me is this cone of light. So cone of light, remember, is in the antero-inferior quadrant. Okay. So remember one thing, no matter what question they ask you, what will your answer be? Antero-inferior quadrant. Cone of light kahan hai? Antero-inferior quadrant. Where do you have most common perforation? Antero-inferior quadrant. Where will you give an incision if you want to drain fluid? Antero-inferior quadrant. Just one complication here. So myringotomy that we do for serous otitis media most commonly, and grommet insertion, it is in the antero-inferior quadrant. The incision you give is a radial incision. The only exception is when we are doing a myringotomy for ASOM, acute serous otitis media, then I give a curvilinear incision, and this is what is happening in the posterior-inferior quadrant. So AIQ ki jagah PIQ. Okay, so this is what a myringotome looks like. So this is the incision. Either you give a radial incision in serous otitis media, S and R are together, or you give curvilinear incision in the posterior-inferior quadrant. Fine. So the moral of the story is AIQ most important, not AQI, AIQ, right? So antero-inferior quadrant. So here, can I look at cone of light and know what side ear it is? Yes. So you will remember this. 7 को उल्टा करेंगे तो L बन जाएगा. So if I see the antero-inferior quadrant or the cone of light at 7 o'clock, it's the left ear. If I see it at 5 o'clock, it is the right ear. So remember 7. So here you can visualize the clock. This is 5 o'clock, right? So 12, 3, 6, 9, all of you know that. So this is 5 o'clock. So this is what is the right ear ka figure. Agar yahan pe hai, it means it is the left ear. Have you understood? So what all are we seeing? We are seeing the handle of malleus. The projection of handle of malleus on tympanic membrane is called umbo. Umbo se niklega cone of light se direction I will know. Then I signify everything at antero-inferior quadrant. If for some reason I don't see cone of light, I can always visualize the malleolar folds and know what is anterior, right? And we learnt about myringotomy. So this is all about the tympanic membrane. Now let's go inside into the middle ear. So middle ear anatomy, this is where we need to learn the contents of each and every wall, right? So let's do this. So middle ear, first of all, lateral wall was the tympanic membrane, right? So imagine we are going on a journey, okay? So we have opened the door, which was the tympanic membrane, and this is the view that I am getting. So I'm looking at it from lateral to medial. I've opened the tympanic membrane, and what I see here is the medial part, right? So across this door, what is living? It's the inner ear, right? So this is the orientation. ये वाला part is the anterior wall. Let's start easiest with the anterior wall. Remember, anterior wall के लिए T. T structures are anteriorly. What are T structures? So we have the tensor tympani muscle which is passing through the anterior wall, and you can see here it forms this processus cochleoformis. So this tensor tympani is going to go and attach on the handle of malleus. So I'm going to write here, it's going to attach to the handle of malleus that we saw through the tympanic membrane, remember? So on the medial wall, there is a processus cochleoformis. E is the eustachian tube and A is the internal carotid artery. So T structures are anteriorly. In addition, internal carotid is surrounded by the sympathetic plexus, which forms the tympanic plexus here. So that's done. Then you can also see one tiny nerve. So chorda tympani emerges from posterior wall and goes via anterior wall. And this canal, tiny little canal through which it goes, is canal of Hugier. Okay, I may be wrong in the pronunciation, but just remember Hugier. Okay, so this is chorda tympani. Fine. So these are the things which I have anteriorly, T and this canal of Hugier. Okay, so this is anterior. Let's finish off two easy ones, roof and floor. Roof is tegmen tympani. This is nothing but the separation of the ear from the skull base. So that's tegmen tympani. Then inferiorly we have internal jugular vein, IJV. Then we have two walls which are complicated, medial, posterior. So let's do the details. Medial wall pe kya hai? So first of all, I see the promontory, right? What is promontory? It's this bulge that I am seeing. It is the bulge of basal turn of cochlea. So it is the prominence of the basal turn of cochlea which is living, inside in the medial part, in the inner ear. So that bulge is the promontory. First thing, you can see the tympanic plexus over it where we are having sympathetic supply. You are having supply from lesser petrosal nerve, your Jacobson's nerve. Together they are all going to form this supply. Okay, so that's done. Then I have processus cochleoformis and I have two windows. So oval window is covered by stapes and this is our round window which is also called as the secondary tympanic membrane because it's covered by membrane, right? So I have oval window and I have round window. Then I have two prominences. What are these two canals? So first is the lateral semicircular canal and below it is the facial nerve which is running in the medial part. So this is what is called as the horizontal segment of the middle ear. So horizontal run kar raha hai and this is running in the fallopian canal. Bony canal called fallopian canal, right? So we have lateral semicircular canal and the facial nerve and this is processus cochleoformis and this is what they say forms the landmark for the first genu. First genu inside hoga. We will learn in the facial nerve course that inside in the inner ear we are going to have the turn. So geniculate ganglion or basically the first genu uska landmark hai processus cochleoformis. So you can remember here first genu landmark. Okay, then I have the second genu. What is the second genu? This is where now we reach the posterior wall. Medial wall में क्या क्या देखा? I have a visual memory. I saw basal turn of cochlea का prominence which is promontory. I saw processus cochleoformis, two windows and lateral semicircular canal and fallopian canal. Great. Now I have reached the posterior wall. So imagine this is the middle ear, right? Just behind this house lives one more house which is the mastoid antrum. Remember I told you we go through the mastoid into the ear. So this is the house where I have the mastoid antrum and there is a window between the two houses. So that's additus ad antrum. Okay, so can I visualize a mastoid sinus here, everybody? Right? So this is how we are going to enter the middle ear. So that's one. Then comes the facial nerve. So this is where I have the vertical segment of the facial nerve. This is where it's taking a turn, giving rise to two nerves. One is the nerve to stapedius. So can you see this stapedius muscle which forms the pyramidal eminence? So this pyramidal eminence is the landmark for second genu. Okay, so this is the landmark where it takes the second turn, right? So that's nerve to stapedius that facial nerve is giving. And then I have my chorda tympani which goes through and through, comes out of canal of Eucure. Right? So this is what is happening at the posterior wall. Essentially facial nerve is running. I have a communication with the antrum. Now let's go to this in a different point of view. So now you have learned what structures are there in which wall. Easy. Now let's look at this image. First of all, get the orientation. The moment I see that this is stapes, I know stapes is covering the oval window. So can I first of all get an orientation that this must be medial, this must be lateral. Very nice. The moment you do that, now you have recognized the facial nerve. You can see the chorda tympani, you can see the stapedius. Now we have to identify these two recesses. Before that, let's identify this also. This is nothing but the pyramid, right? So pyramidal eminence formed by the stapedius. All right, that's done. So now let's get to the recesses. Here I want you to remember Shrimati. You know how previously we used to refer to married women as Shrimati, SMT. So I want you to remember that medial recess is what is sinus tympani, right? So this is what is sinus tympani, whereas the lateral recess is the facial recess. Okay, this is also called as suprapyramidal recess. Okay, even though this is lateral, imagine just head on that this is upper, right? Easy to imagine. So this is suprapyramidal recess, whereas this is infrapyramidal recess. Okay, so this is what I have learned Here, Srimati, SMT. Medial is sinus tympani or infrapyramidal recess. Upper is facial recess or suprapyramidal recess. What is the significance? Remember I said यहाँ पे mastoid antrum है. So if one wants to drill through the mastoid antrum and reach the middle ear, this is their best place to enter. So facial recess approach, can I say, is also called as posterior tympanotomy. I am making an opening in the tympanic area, which is middle ear, through the posterior area. Did I have to dig the canal? No. So that is why this is also called as canal wall up approach. It's a minimally invasive approach through the mastoid sinus, right? So this is canal wall up procedure. Now imagine a surgeon has come inside to clear off all of the cholesteatoma here. Okay, what is the part which is a blind window? Imagine this is a pillar. Do you agree just behind the pillar they cannot see? This is a blind window, and that is why this sinus tympani here is the most common site of residual cholesteatoma. Is that making sense? Because ये part उनको नहीं दिख रहा. They are coming through here and this pyramid is obscuring their view of sinus tympani, and that's precisely the reason why residual cholesteatoma, most common site, is going to be sinus tympani, right? So we've done posterior tympanotomy. Now let's add on to this knowledge a little bit, okay? So this is where you can see an image. So this is what is the pyramidal eminence. Can you see this? So this is the stapedius muscle attaching onto the stapes, and what I want you to see here is this. So this is the sinus tympani, and you can see two things. P above is the superior boundary of sinus tympani, that is called as ponticulus, and niche sub hai, so subiculum, right? So sub means down. So these are the superior and inferior aspect of the sinus tympani. You can also see the round window niche here, right? So this is what we have here. A few words about eustachian tube and its importance. So look at this image. So this is what is the eustachian tube opening, and you can see on both sides we have the levator vela palatini and tensor vela palatini muscles. So these are the muscles which regulate the closing and opening of the tube, and that is the reason why in patients who have cleft palate, right, they don't have these muscles forming this effective sling or hamulus. So this sling is missing, and that's why the tube function gets deranged, and that's why they have recurrent ear infections. The pressure is not able to get managed. So recurrent ear infections in cleft palate can be explained because the palatal muscles never reach there and form that effective sling to regulate the ear opening. The other point, you can also see a pad of fat around it, and that is called as Ostman's pad of fat. If that is absent, you will have a patulous eustachian tube. The opening becomes very wide, and that can result in autophony. Autophony is me listening to my own voice echoing inside my head, right? So that's autophony. In children, the tube is shorter, wider, horizontal, and that results in more spread of the infections, right? So that's why children have more otitis media, because the tube is a good channel to transmit. It's shorter, it's wider, it's more horizontal, right? So that's why they have more otitis media. So that's about eustachian tube. Now, I want you to understand the ossicles, okay? So we'll keep adding on to the layers. So here, what was missing were the ossicles, isn't it? So let's fill the ossicles, and then we'll go more deeper into the surgical approach and posterior tympanotomy. So here, they'll ask you to identify, right? So nobody is going to have a challenge identifying stapes, and that's why they're not going to ask you that. So this is stapes. You can see the stapes foot plate, which will cover the oval window. Which is malleus, which is incus. So you remember malleus, male. Do males have head? Yes, they do, right? Like girls also. So this is where you can imagine there is a head. But here there is no head. It is directly body. So when we have a head, that's where we know it must be a male. Male matlab malleus. So that's how we will identify malleus. Okay, so this is the head. You know, this is the handle or the manubrium, right? This is the anterior process, and then there is one small lateral process as well. Okay, so this is how malleus looks like. Essentially identify the head. When you see directly it's starting from the body, that means this is incus, and this is what is the long process of incus. Just at the terminal aspect, they will have a lenticular process. So don't write that lenticular lens, just a small. So long process of incus. And what is the significance? This is the most common site of erosion in cholesteatoma. So in cholesteatoma, the erosion happens in this long process of incus. So we have malleus and we have incus. Let's have a look at this image where you can see the different structures. I just want you to put a tick mark that do I understand everything? Okay. So let's see. So they have given the orientation that this is superior, this is anterior. So that gives you some insight as to this is the eustachian tube anteriorly. But ignore that for a moment. Ye superior part hai. So do you remember epitympanum? This is the Prusac space. Okay. Then what can I see? I can see the manubrium sternum and the umbo where it will attach to the tympanic membrane. Lateral process ho gaya. Long arm and lenticular process of incus. So this is a long process of incus, and this is the stapes which is attaching at the stapedius, that's the pyramidal eminence. Near the pyramidal eminence, do you remember medial and lateral? So this is sinus tympani here, whereas this is our entry point, facial recess. So this is what the surgeon wants to enter from. And this part here is also called as fossa incudis. You can see ye pura incus hai. So this is fossa incudis, and that is one of the boundaries of the facial recess, right? So can I say what would be the boundaries of facial recess? It's pretty simple. I have pyramid, I have chorda tympani, and I have the fossa incudis here. Okay, so just keep this picture in mind कि pyramid था, chorda tympani था, and अब इस image में देखा, this is where the incus is. Okay, so fossa incudis. What else can I see here? You can see ponticulus subiculum. You can see the promontory, round window here. So this is oval window. This is round window. Right? I think that's all. And you can see the Jacobson's nerve. So did you get an idea of what all things are there? You can also see the tensor tympani attaching on the handle of the manubrium. Okay, so this is all about the anatomy here. So you just want you to be comfortable with this picture. Okay, it's an extension of what we have seen. Now let's get to how did you reach to the posterior tympanotomy. So we will drill on the mastoid. So let's start from the very basic. What is the external landmark where we have to drill? Where is the mastoid antrum living? So this triangle here is called as the McEwan's triangle. What are the boundaries here? So the superior boundary is nothing but the dural plate, right? So this is what is the dural plate, which is the upper part. This is also called as supramastoid crest. So that's the superior boundary. Anteriorly, what we have, so this is where you are going to have the external auditory canal. So this is what is called as the spine of Henle. So spine of Henle is what is the posterior-superior margin. You can see it's superior at least, posterior-superior margin of EAC, and then one line is a tangent joining the two. Okay, so that's a tangential line to EAC. So tangential line to EAC. So just remember two boundaries, supramastoid crest or dural plate, spine of Henle, and then just connect these two. So this becomes the McEwan's triangle. The surgeon will have to drill 1.5 centimeter deep to this, and they will find the mastoid antrum. Okay, so mastoid antrum is where you have the mastoid air cells. So now let's look at an X-ray of this particular part. Can you see the external auditory meatus? So this is somewhere where we have the McEwan's triangle, and can you see on the X-ray how these are all these small air-filled mastoid sinus? So here we draw an angle. So what is this particular angle that we are seeing? So the superior line is the dural plate, whereas this is where I have the sigmoid sinus. So sigmoid sinus, dural plate. This particular angle is what is called as the Sittel's angle, or I can say the sinodural angle. So Sittel's angle or sinodural angle is what will tell me how well are these mastoid sinus pneumatized. Can I say that if this angle decreases, it means that the mastoid is sclerosed, है ना? Sclerosis हो गया है. So this is what is the importance of this X-ray, and what is this view called? This is what is called as Law's view or Schiller's view. which tells us about the mastoid pneumatization. So before doing any surgery of the mastoid, they're gonna get this X-ray done to see the degree of mastoid pneumatization. And if everything is normal, now what will they do? They are gonna go to this McEwen's triangle, drill 1.5 centimeter deep, and then they reach something like this. Okay, so now let's again get the orientation. So imagine the patient is supine, right? Look at this view. Can I say this is the part which is nothing but the sinodural angle that we were looking at? So this part here is the dural plate. Patient is supine, right? So this becomes the superior part. So this is the dural plate, and the posterior wall, this is the posterior wall. Can you see the sigmoid sinus blue? So this is the sigmoid sinus, and these are all the air cells that we are seeing. And now what can you visualize? If I go in anteriorly, you understand, I'll reach the middle ear. So this is our posterior tympanotomy that they have drilled and they have gone inside. So what all are the landmarks? Lateral semicircular bulge. This is a PYQ. Fossa incudis की बात हुई थी. So I'm seeing the incus, I'm seeing this facial nerve, and what is this thin nerve? Chorda tympani, right? So I'm seeing the two landmarks I talked about. I'm seeing the chorda tympani, I'm seeing the incus, and this is where we have entered into the middle ear. Okay, so this is what is your facial recess approach or your posterior tympanotomy approach, right? Yeah, so just another perspective which they can ask you as a figure. So they have made a posterior tympanotomy through which you are able to see the structures of the medial wall, right? Jacobson's nerve dikh raha hai. All right, so this is what we are seeing inside. So what are the boundaries? So we are seeing the facial nerve. Can you appreciate vertical, second genu ka landmark tha pyramid? Are we seeing that? Right, so this is what we are seeing, that this is the turn from the horizontal to the vertical segment. So we are at the posterior wall. Lateral semicircular bulge tha on the medial wall, and this is posterior because I'm looking at it from the posterior wall. So they can ask you this perspective as well. Okay, so this is where just get the orientation. So jahan pe bhi vertical segment hai, ye posterior hai. So this becomes posterior. Horizontal segment and lateral semicircular were anyways parallel to one another, and I'm seeing the pyramid at the second genu. So you can always fit with what information I've taught you in the anatomy. So just trying to get you comfortable with multiple perspectives. Okay, two theoretical questions. So we did the McEwen's triangle. There's one more triangle which is called as the Trotman's triangle. So Trotman's triangle is what is the boundary of the posterior cranial fossa. So they can just ask you independently, posterior cranial fossa access kahan se karenge? We'll do it through Trotman's triangle. What are the boundaries? So we have superior petrosal sinus, naam mein hi hai superior. Sigmoid sinus posteriorly, yahan pe bhi sigmoid sinus hai, and anteriorly bony labyrinth. Okay, so this is Trotman's triangle. Then there is a anatomical variation called corner septum. So corner septum is what is a persistent petrosquamous suture. Both of these are parts of the temporal bone, petrous temporal, squamous temporal. So if there is this suture within the mastoid sinus, and let's say somebody has mastoiditis and I'm trying to drain the pus, this part will always remain. It's like a wall, it's like a hidden chamber because of a persistent wall, and you didn't know that wall was an anomaly. So that is corner septum, and this is why before any mastoiditis they'll also get a CT done so that we can look for these anomalies. Okay, so corner septum is what is, just remember the question, it's a persistent petrosquamous suture and will result in incomplete clearance, right? Because you didn't know there was this extra room which was to be cleared. So incomplete clearance hoga disease ka, and this is persistent petrosquamous suture, PS. Now we have reached the inner ear. Okay, so we have done external, we have done tympanic, we have done middle, we have reached middle through the antrum. Now what's happening inside? Inner ear. So inner ear, now you understand two things. We have the bony labyrinth and we have the membranous labyrinth. So the membranous labyrinth is filled with endolymph, and then I have the bone outside. So in between these is the perilymph. Okay, so we have two fluids circulating in the inner ear within this membranous folded structure that you can see here. This is the membranous labyrinth. I have the endolymph floating, and outside it is the big bony plate, and between them is the perilymph. So let's understand what are the structures. Three things essentially. We have the semicircular canals, we have the vestibule made up of utricle saccule, and we have the cochlear duct. So can you see this cochlear duct forming 2.5, or to be precise 2 3/4 turns it folds, right? Any turn will be around a center. So what is the bony center around which this is turning? So the bony center around which cochlea takes a turn is called as modulus. Okay, modulus is the bony center around which the cochlea takes these 2 3/4 turns. All right, so that's cochlear duct. Then the vestibular duct is going to be formed by utricle and saccule, so that's the vestibule. And then I have three semicircular canals. What are the three? I want you to first remember SAP. Anterior is the same as superior and posterior. Okay, so we have superior / anterior semicircular canal, posterior semicircular canal, and horizontal, which is also called lateral. Why are we remembering SAP? Because S and A are the same, and P. Together, they have one common opening, which is called crus commune. Okay, so I have a total of 5 openings, right? Both of the semicircular canals are fused. So basically 3 twos are, they were supposed to be 6 because one is fused. There are 5 openings. So this is what we have. So the crus commune is the fused opening of SAP. Superior anterior same hota hai and posterior. So that will help you remember. Horizontal is lateral. And all of these semicircular canals are arranged perpendicular to one another. And can you see that there is one duct which is coming here and draining this fluid from the vestibule? So what is this? This is what is the endolymphatic sac, right? So endolymphatic sac is coming and draining this fluid from the entire membranous labyrinth. And you see some organs mentioned here, right? We can read crista here, we can read cupula here. So what are the sensory organs? So let's do this. So in the semicircular canals, we have crista. What is their job? Their job is to help us in dynamic / rotational stability. Right? So if you go on a roller coaster ride that's moving round and round, the organs which are stimulated are cristae. Linear, right? So maculae is for linear stability, up and down. So utricle here is going to be horizontal stability, whereas saccule is going to be vertical stability. Okay, so you can again remember U gear, hush. So this is HU. All right, so horizontal is utricle, saccule is vertical. So this is for linear stability, whereas round and round, rotational, cristae. So maculae are the sensory organs here. Organ of Corti are for hearing. We will get to that in the cochlea. So the vestibule and semicircular are done. Now let's talk about the fluid that we were talking about. So endolymph, which is circulating in the membranous labyrinth. Where is it produced? Very important. It is produced by stria vascularis. Okay, so stria vascularis is this capillary fold which makes this. And where is the absorption? So as we said, it circulates in this endolymphatic sac, and that is where it is going to go. So this endolymphatic sac is nothing but the drainage of the vestibular aqueduct. Aqueduct matlab passage. So this is the vestibular aqueduct, and it opens up into this endolymphatic sac. Okay, so this is where endolymph gets absorbed. Perilymph, on the other hand, is circulating between membrane and bony labyrinth, and this is what is an ultrafiltrate of CSF. Okay, and this is what is draining via the cochlear aqueduct. So C and C, CSF, cochlear aqueduct. What is very important is how are they? Okay, so remember Ken. You know how we have Ken doll, Barbie ke saath Ken doll. So endolymph is what is rich in potassium. Okay, so this is rich in potassium means, can I say endo is inside? It's similar to intracellular fluid, whereas perilymph is rich in sodium, outside hai. So this is what is equivalent to extracellular fluid. Okay, so remember Ken, and that will be enough. Okay, so endolymph, who made it? Stria vascularis, going via vestibular aqueduct into endolymphatic sac, whereas perilymph, ultrafiltrate of CSF, circulates via cochlear aqueduct. And the importance is that anybody who has meningitis, right? Do you agree? That can reach the ear, and that's why one of the complications of meningitis is sensory neural hearing loss, and the condition it can result in is called as labyrinthitis ossificans, right? So it can lead to infection into the inner ear, right? So this is the significance. It's via cochlear aqueduct, because essentially the fluid circulating in the ear is from the brain. So if brain ka CSF infected hai, it can reach the ear, right? So this is what we are seeing here. Now, let's do the cochlea. All right. So, in the cochlea, if we take a cross section, if I take a cut through the cochlea, I am going to see something like this. So, if we cut, imagine this duct, we are going to see this cross section. Very, very important. I'm sure you have done this in your undergrad, right? And this is a figure which always comes for us to draw. So, this is where you will remember vestibuli, scala media, scala tympani. स्केला वेस्टिबुला के पास कौन सा कवरिंग है? This is where I have the oval window, and नीचे we have the round window. So this is where we have the round window, ऊपर we have the oval window. So basically this is scala vestibuli, this is scala tympani. Remember we said a phase difference thing. Why is it important? Because if both of these get the sound wave at the same time, now there will be no effective vibration here. But if this reaches faster, do you agree now effective vibration can happen? So that was the importance of that phase difference that we talked about, that now both of them will be stimulated at different times, and that results in the vibration which stimulates these organ of corti. Yeah, so that was what I wanted to teach you now. So let's understand. So scala vestibuli, scala tympani, this is where I am going to have perilymph, whereas scala media is this tube right here, right? So scala media is what is the membranous labyrinth tube, which is filled with endolymph. So remember pep talk, PEP. All right. Now, what do we have here? So this is what is called as the Reisner's membrane, and what is the most important one is this basilar membrane, because on the basilar membrane lives our sensory organ of hearing, which is the organ of corti, which when they get stimulated through this differential vibration will conduct, and this energy is transmitted into the vestibulocochlear nerve via the spiral ganglion. All right, and can you see the stria vascularis here? So this is what was supposed to make the endolymph, right? So this is stria vascularis. These are organ of corti. Let's go further into organ of corti. We have two main layers. One is outer hair cell and one is inner hair cell. Inner is I is 1. So this is one row, whereas outer hair cell you can see are 3 rows. So remember, I is I. Inner hair cell is the one which is going to transmit the sound. Transmit the sound. So you will remember 1. Okay, so this is what will transmit the sound into the spiral ganglion. So this is what is the afferent of spiral ganglion, and it basically uses this mechanical energy produced by the stretching of this membrane, which is the basilar membrane, right? So basically when the basilar membrane shows differential vibration, this membrane covering organ of corti, that's called tectorial membrane, undergoes shearing. खींचा जाता है. So it is stretched, and that is what stimulates the inner hair cell. So it converts this mechanical energy into electrical energy via glutamate. So it releases glutamate, and that is how the nerve is fired. Vestibulocochlear nerve will now take it, and we'll see rest of the pathway. Understood this? So differential stretching, tectorial membrane stimulates inner hair cell that transmits the sounds. Outer का काम क्या है? They just modulate. So they modulate the input, right? So modulate and 3 rows. That's what I have to remember. There is also a gradient as to how they will perceive sound. You know how we study that the apex of the lungs does not get ventilation because it's against gravity. So just that point I want you to remember. So low frequency sound, low ventilation is at the apex, whereas high frequency is at the base. So can I put it in this way, that basal turn of cochlea, what was that? Promontory. So जो promontory बनाता है, basal turn of cochlea, this is what is gonna get the high frequency sounds, whereas low frequency is apex, and apex का hallmark, anatomical landmark is tremor. That is what is the apex. So apex helicotrema पे क्या जाएगा? Low frequency. Remember, low frequency, low ventilation. All right. High frequency, base of turn of cochlea. So this is what we have learned here. Then you can also see some named cells: Henson cell, Claudius cells, Bocher cells, Dieter, Pillar. All of these are the supporting cells. Okay, so best actor in supporting role are all of these. So supporting cells. Okay, so this is where we have seen that I have the inner hair cell, which is the main afferent of the cochlear nerve, and we have some output which is modulated by outer hair cell. So this is about it. They asked you the HRCT image. This was neat, all right. So very, very difficult question here. So look at this. This is an HRCT. So for ENT, if you have to choose one answer, whether it's paranasal sinus or it's inner ear, the investigation of choice is high resolution CT, because you know CT shows air and bone the best, and that's all I have in paranasal sinus or ear, air and bone, right? So I don't have to give contrast, right? So this is HRCT. I can see the bones very well. So this is what we call as the bone window. Just try and understand. I mean, I never thought I would teach undergrads HRCT temporal, because even JRs don't understand it very well. But because they have asked, now we have to do. So this is what is the internal auditory meatus. This is where the vestibulocochlear nerve will enter. So this becomes the inner ear. This entire part is inner ear. And can you see just lateral? ये part medial है, ये part lateral है. Just lateral to it is this air-filled middle ear. So this part is the middle ear. What you see inside white dots are nothing but the ossicles, which are bones, right? So white हो गया. So ये middle ear है. So उससे medial ये पूरा part, this entire part here is the inner ear. And do you understand ये anterior है, ये posterior है. So what is posterior to middle ear? So this is mastoid. Now do you understand the complete picture? हम यहाँ से आए, went into mastoid, and through that now I am reaching in the middle ear. Okay, so this entire part here is the inner ear. How are they arranged? So this part, you can see this round thing. This is the semicircular canal. We'll only see one because we're cutting. This is the vestibule and this is the cochlea. So cochlea will look like a flower. It will be wound like a flower with the spiral lamina. Let me draw again. So there is an osseous spiral lamina around which it is taking these 2, 3, 4 turns. So I will see something like this. You know how in cards we have clubs? So the cochlea looks like this clubs. Okay, so I have the internal auditory meatus with the vestibulocochlear nerve going into the cochlea. Vestibule है and semicircular canal है. So can you tell me what must be this duct coming from the vestibule? So this is the vestibular aqueduct, right? So this is what is the vestibular aqueduct, and where will it close? Endolymphatic sac. So this is vestibular aqueduct. This is actually dilated vestibular aqueduct. So this should always be narrower than the meatus. In this case, it is dilated. So it is absolutely shocking that they have pointed to either one of these structures and asked you. So अब क्या करना है? जो आगे है, आगे is internal auditory meatus. जो पीछे ग्रे है is the vestibular aqueduct. So one more time, let's try and do this. So जो पीछे है, this is the vestibular aqueduct. Then here we are not seeing the internal auditory meatus. We are slightly asymmetric in the section, but this is the cochlea. This is the semicircular canal, right? So obviously you are not supposed to be understanding it, but if you are, it's a bonus. So one more time I'll try. Mastoid, kala, middle ear filled with hair, so that's why black. Internal auditory meatus opens into cochlea, whereas उसी के पीछे जो parallel है वो है vestibular aqueduct. Right, so that's the CT anatomy here. So now we're going to be talking about middle ear diseases, and I'm going to show you the pictures because the diagnosis is going to be made on external examination, right? So we're going to be looking at it through the tympanic membrane. So let's have a look at these images and try to study these diseases right here, right now. First one, the most commonly asked one. So this is where, can you see how the tympanic membrane is bulging? A lot of times you may also see some bubbles here. So what does this indicate? That there's fluid which is collecting inside the middle ear. So this is what we call as serous otitis media also called as glue ear, right? So this is what is called as glue ear. Now, why would fluid collect in the ear? So the cause again goes back to the eustachian tube. If it is unable to drain the ear, the fluid is going to collect. So now two causes here that we need to remember, and both of which are essentially the eustachian tube getting blocked by the outside by a nasopharyngeal lesion. So if you see that there's a child, right, a young child who's having serious otitis media, straight up the most common cause becomes adenoids, right? Must be the adenoids in the nasopharynx which is blocking the ear. If you see that it's an elderly patient, right, then what do I suspect? Then I suspect that it's a nasopharyngeal carcinoma which is blocking the eustachian tube. And we learn soon when we go to the pharynx that there's a fossa of Rosenmuller where this cancer begins, and that is where the tube gets blocked, right? So serous otitis media or glue ear is what I need to remember, and this is what we will learn for the causes. Obviously, I have to treat the primary cause, and only then there's a point of draining the fluid, right? Otherwise, it will keep on accumulating. So that is what the management would be. So a lot of times they'll ask you this in a child, that a child is a mouth breather. He cannot breathe through the nose, and now he's having hearing loss. So that's where you add 1 and 1, make it 11, and say that it's adenoids which is causing the hearing loss and the nasal obstruction, right? So that's where the treatment then becomes, you have to do adenoidectomy and then I have to drain this fluid. How do we drain this fluid? So I'm going to give an incision. Remember, myringotomy we are going to do where? In the anteroinferior quadrant. So if I ask you which ear is this, you look at the cone of light, you see it's at 7 o'clock. So you tell me, ma'am, this is the left ear. And can you visualize how just where the cone of light is, I've put a grommet. So we do a myringotomy and we put a grommet. So this is a figure which is showing you the grommet insertion to drain out the fluid. So the treatment of serous otitis media is myringotomy plus grommet insertion, and as soon as the fluid is drained, the ear is dry, the grommet falls off on its own, right? So it's very efficient that way. So this is what we need to remember, and they've asked this question on the causes of glue ear multiple times. Then look at this. This is where you see a reddish mass, and this is what is a very vascular tumor which is called as glomus. If it is in the ear, like in this case, it's glomus tympanicum, but it can also be in the jugular fossa, and then we call it glomus jugulare. If they are both, then we call it glomus jugulotympanicum. Okay, so when I see it in the ear, it's tympanicum for sure. If they show you a CT, jugular fossa, it's jugulare, right? So now what are the signs described for this lesion? It's a very vascular tumor. Glomus is nothing but a paraganglioma. I'm going to write it in red because it's vascular. Okay, so that is paraganglioma. So because it's so red, it's looking like a rising sun. So it's just based on the physical appearance. Then what is aquinosign? Aquino, AQ, make it IC. So this is for the artery, right? So aquino is the internal carotid artery, which is what is supplying this glomus. So they say that if you block the internal carotid artery or the common carotid artery, if you occlude it, what's going to happen? This lesion will blanch, right? So that proves that it's a vascular lesion. What is brown sign? Brown sign is also similar, using seagulization, using a seagull speculum. When you change the pressure of the ear, again it will show blanching. The Phelps sign is particularly for your glomus jugulare, where we see the jugular spine erosion. So if there is a spine erosion by this very vascular mass, that's called the Phelps sign. And the staging system here is called the fish staging. The entire staging not very, very important, but just remember this is what is glomus. Then you can see a very painful condition. This is where the patient will have very severe ear pain, and on examination, can you see some bullae and vesicles? So this is what is called as bullous meningitis. Okay, so bullous meningitis is where you have severe bullae. The most common cause of this is S. pneumoniae, same as otitis media that I'm about to teach you. Apart from that, this can be seen because of herpes as well as mycoplasma. So these are a few causes. Buzzword is bullae and pain. Okay, then look at this, very, very important. Can you see so much hyperemia is happening? So it starts to look like a cartwheel. So this is what is the cartwheel sign. Why so much hyperemia? Because of infection. So this is acute otitis media. Let's talk about this. So acute otitis media, again, most common cause pyogenic. So it is S. pneumoniae caused by a bacterial infection. Happens more in children. Remember we said eustachian tube is more horizontal, so infection can rise. So that's the cause. Now what are the stages? So the first stage is stage of obstruction, where the eustachian tube is obstructed and now slowly the inflammation is starting to increase. Then we have a stage of pre-suppuration. So this is where the pus is not at its maximum, right? So pre-suppuration stage is the stage where I'm seeing hyperemia, this cartwheel sign, the infection is starting to get its pace, right? So this is pre-suppuration. Finally, it reaches its maximum peak, which is the stage of suppuration, and this is where you can literally see the tympanic membrane bulging red, and that is called a lighthouse, inflamed red tympanic membrane like a lighthouse. And this is where, because pus is maximum, this is where pain is maximum, right? So this is where pain will be maximum in the stage of suppuration, and then it undergoes resolution. So resolution could either be achieved because of your treatment, antibiotics that we have given, or the ear will find its own way. What will it do? It will release. It's, filled with pus. So it finds an outlet. It creates a perforation. So that is where you will have a tympanic membrane perforation and the pus is released, right? So there are two ways to resolve. Either you do it or the ear will do it itself through damage. Okay, so these are the stages of acute otitis media. The treatment obviously is antibiotics, right? So obstruction, pre-suppuration, suppuration, resolution, maximum pain obviously when it is maximum pus. Look at this. So this is where you can see two perforations, right? The perforations in the tympanic membrane, white, cheesy material. What does that remind you of? Caseous necrosis, right? So TB. So this is what is TB otitis media. The hallmark of TB ear is that there is no pain. So this is where the buzzword is painless otorrhea. Discharge hai, no pain. Buzzword, there can be high chances of perforation and we will see caseous material. So that's TB, buzzword being lack of pain. Right, so these are all of our middle ear diseases, particularly otitis media and serous otitis media that we have to pay attention to. Now let's get to cholesteatoma. So cholesteatoma is what is, in one word, skin in the wrong place. If you have to remember in one line, skin in wrong place. What is skin? It is squamous epithelium. So when you have squamous epithelium coming inside the middle ear, that's a cholesteatoma, right? Now it could be primary cholesteatoma. Remember I told you again, who's at fault? Eustachian tube. The eustachian tube is not balancing the pressure, because of which we are going to have retraction. So eustachian tube dysfunction leading to retraction pocket, retraction of tympanic membrane. And what part of tympanic membrane? Upper part. What was upper part? Do you remember? Pars flaccida. So this is where there's going to be a retraction of the pars flaccida, through which now the cholesteatoma can enter, or there can be a pars flaccida perforation as well. So look at this image. Can you see how there is a debris of cholesteatoma upper hai? Can you see this is the tympanic membrane? So it's in the pars flaccida. This is the pars tensa. So that's what is primary cholesteatoma. All of these cholesteatomas have one theory which people had given, which I am teaching you. So who gave this theory of primary? It is Whitmax. Okay, so Whitmax has given this theory of primary cholesteatoma. Then we have secondary cholesteatoma. As the name suggests, now there is a perforation. You have full rasta for the epithelium to enter, right? So this is where, can you see in this image how there is a central perforation now, big central perforation in the pars tensa, through which the disease will enter. So this is where you have a perforation, kaisa perforation, central perforation or pars tensa, through which the cholesteatoma disease enters. And this theory is Haberman's theory. Okay, so Haberman, Whitmack. Congenital cholesteatoma. There is no retraction, there is no perforation. So this is where we have an intact tympanic membrane, and can you see this is what has been described as a pearly white mass. Pearly white mass with intact tympanic membrane will be the phrase they will use. So this is congenital cholesteatoma, and here they said How did this happen now? So they said that there were some congenital cell rest. The cells were already there. That's their explanation. So congenital cell rest were there and they turned into cholesteatoma, and this theory was given by Levinson. Okay, son hai, so it is congenital. So Levinson. Okay, so this is what we need to remember. Now, retraction has gradings, right? So retraction of the pars tensa. I will be tensed, so I will be sad, right? So remember, you if you are tensed, you are sad. So SAIDS is pars tensa, whereas TOS grading is pars flaccida. They had asked the details of the SAID grading using a picture, so I'm just trying to show you that. So look at this. What is the SAIDS grading? So let's just learn one. Okay, so SAID is where there is just retraction because of the eustachian tube dysfunction. Grade 2 mein now the retraction has come to incus. So first the tympanic membrane is still malleus, now it's reaching incus. Grade 3 and 4, now it has reached till the promontory. Can you see? It has reached the promontory. 3 is where it is not adherent, 4 is adherent. So how do I distinguish that? Using seagulls. If it moves on seagulls, it is 3. If it doesn't move, it's fixed, it is 4. 5 is where you have a perforation. So look at the images. So 1 is where you can just see the malleus, right? You can see the handle of malleus. Look at 2. Now I'm seeing handle of malleus. I'm starting to see the incus also. Look at 3. Now I'm starting to see a lot more. Can you see? I'm seeing the middle ear, promontory, all of this stuff. And 4. 4 and 3 I cannot distinguish without seagull, so they may not ask. But just see how many structures you are seeing essentially. So that will tell you how inside has the tympanic membrane gotten. Okay, so this is all about cholesteatoma. Now let's get into CSOM. What is CSOM? So it is chronic suppurative otitis media. This is where now we have a permanent perforation. Okay, so there is a permanent perforation and there's going to be persistent discharge. So there are two types. You have tubotympanic and atticoantral. What does that tell you? Atticoantral. Attic upar hai. Additus ad antrum communicating with the mastoid antrum, right? So this is the upper part. So this is what is going to happen in the epitympanum, pars flaccida, right? Can you all visualize that? So upper pars flaccida hai. This is the bad type, right? So this is the one which is also called as the unsafe ear. On the other hand, tubotympanic part is where you have a central disease, tube, right? Tubotympanic. So we are having the tympanic membrane central aspect. So this is what is called as safe ear as well. So atticoantral upper part, pars flaccida, that's the bad one. So this is where we are going to have a retraction pocket, cholesteatoma, everything that Whitmax described, marginal perforation of pars flaccida. On the other hand, recurrent otitis media, remember I told you the end stage is perforation. So this is pars tensa perforation. Tubotympanic, this is the important part. Here you have profuse discharge. So remember, more discharge is not bad. Here, more discharge is in the better type. Scanty discharge, other words you will help you. Purulent hai, foul smelling hai, pata chal jayega. But the amount you have to be careful is opposite. Profuse is in the safe type, okay? Then, more chances of granulation tissue and polyp in the unsafe ear, right? And this is where they also say never ever avulse this polyp. Never remove it. It will bleed, right? Complication obviously more in the unsafe type atticoantral. So there's high chance of bony erosion by this cholesteatoma. So what did we learn here? The earliest erosion is in the scutum because it's in the epitympanum itself. Most commonly I told you long process of incus. Right? Because long process of incus is the most common, we assume कि वो सब में है, it's there in everybody. So Austin classification was given for degree of bone erosion and he looked at two structures. He looked at the handle of malleus and he looked at the stapes suprastructure, right? So stapes suprastructure. So based on this, the Austin classification is based basically how much is the erosion, right? Because we're assuming long process inka sab mein hai. What about the other two, right? So that's Austin for you. This is the one which will have complications like facial nerve, intracranial complications, and I'm going to teach you a bunch of other complications, right? So this is your CSOM, unsafe versus safe type. So now let's get into the complications. So the most common complication is that now this infection spreads into the mastoid, right? So this is what is mastoiditis, and mastoiditis, you can see this is the sign where this is called as reservoir sign. Okay, it is filled with pus, reservoir, bulging. Okay, so the first sign that we are gonna see is ironed out mastoiditis. Again, bulging, but when it really bulges, it's called as the reservoir sign. We can also found soft tissue abscesses. So the most common soft tissue abscess is going to be retroauricular, right, behind the ear. Bezold abscess is sternocleidomastoid abscess. C and D go together, remember? So Citelli is an abscess in digastric muscle. C and D go together. Look is 3-letter, ESC is 3-letter, external auditory canal. So how to remember? Most common behind the ear, I can see that. C and D go together, look ho gaya. So whatever is left is bezold, right? So that's how I've remembered this. Right, now intracranial complications. The most dangerous complication is sinus thrombosis, right? So this is where in the CTV, so this is the temporal bone. This is where I have my transverse sinus. This is the location of the transverse sinuses. So it is in close contact, right? So remember sigmoid sinus. So the upper part of sigmoid is going to be transverse sinus. So transverse sinus thrombosis or lateral sinus thrombosis is one of the most dangerous complications here. So that is what is called as Greisinger sign. Remember this? The moment I see this, I think of battle sign, isn't it? But there's no trauma here. This is not battle or middle cranial fossa fracture. If the history is of CSOM and you see something red behind the ear, this is called Greisinger sign, and it's an indirect sign of lateral sinus or transverse sinus thrombosis. Any sinus thrombosis, there are two ways to diagnose it, remember. One is on NCCT, it will look white because the acute thrombus will be white. So can you see here how there is a white thrombus on the right side? But if I am doing a CECT, I will see a filling defect. Okay, you remember delta sign. So a lot of ENT faculty teach delta sign, but the delta sign is for superior sagittal sinus, which enters like a triangle, not here, right? But I'll just tell you how it will look if it was a CECT. If it is a CECT, the vessel will be white, right? This entire sinus will be white and the thrombus will not pick up contrast. So it will look like this. It will look like a filling defect. Okay, so I just want you to remember that this is hyperdense or filling defect. The term delta sign is used here, but it's not correct. That's particularly for superior sagittal sinus thrombosis. But just remember, right, that delta essentially what they are trying to ask is a sinus thrombosis. Fine. Apart from that, there are two signs, clinical tests to detect this sinus thrombosis, but they are not done in practice. So let's understand. So the concept for both of these is that if I compress on the IGV, right, internal jugular vein, that's where all sinuses drain. So if I compress, the outflow should stop and there should be an increased venous pressure, isn't it? But here, because there is thrombosis, that increase in pressure will not happen. That's the concept. Ki IGV, the bane par, on compressing IGV, that pressure does not increase. So there I can measure the CSF pressure or I can see venous engorgement. So those are the two tests. So Toby-Ayer is an invasive test where I measure the CSF pressure. So upon compressing IGV, both of these are on upon compressing IGV. Normally क्या होना चाहिए था? Normally pressure should have increased. Here it will not increase. Krobeck test was an ophthalmologist, let's assume. So he is doing a fundoscopy and looking at retinal veins. So he will see that upon compressing IGV, again, normal hona chahiye tha that the retinal veins increase in size. They become engorged, but not here. Right? So these are not done just for completion's sake. So remember, Krobeck is for the eye. Okay, whereas Toby-Ayer, जिसमें I actually आता है नाम में, is not I. I is not I. So Toby-Ayer is for CSF. Krobeck is for retinal veins. Okay, so that's what I have to remember. You can have fever which is rapidly rising like a picket fence. That's what they describe it as. So these are all complications related to lateral sinus thrombosis. What is this image showing? One more intracranial complication, that's abscess. This is the temporal lobe, this is frontal. The moment I see pons, this is cerebellum. Don't call it occipital. So two of the commonest side that ear is in contact with or mastoid is in contact with is either temporal lobe or cerebellum. So we can have a temporal lobe abscess or a cerebellar abscess, right? So that's what is the other complication. Grade-Nigo syndrome is an apical petrositis. So again, you have an inflammation here in the mastoid, it can reach petrous apex. This petrous apex is important because this is where two cranial nerves go, fifth and sixth. So that's the triad that we will learn. Fifth se kya hoga? I will have retroorbital pain. Sixth cranial nerve, LR6, will result in diplopia. So we have diplopia, retroorbital pain, and we are going to have persistent ear discharge, right? That's the primary pathology. So just remember, at the petrous apex, I have 5 and 6. So these are all the complications of CSOM. So now let's talk about the management of whatever we've studied so far, okay? So if you have CSOM, which is resulting in either a tympanic membrane perforation or ossicular destruction, what can I do? This is what is called as tympanoplasty, fixing the middle ear, isn't it? So this is tympanoplasty and this is Wolstein's classification. Very expected. It's surprising they have not asked this yet. So this is very, very expected. So Wolstein's tympanoplasty essentially is fixing the middle ear, tympano. So type 1, just a perforation of tympanic membrane. So this was asked that if you have acute otitis media with a persistent perforation, non-healing perforation. So what is the indication? Acute otitis media with non-healing or any basically acute or chronic, just remember non-healing tympanic membrane perforation. When do I say non-healing? You have done the management antibiotics for 3 months. So in 3 months, if the perforation is not healed, we have to do a myringoplasty. This is where you're going to place a graft over the malleus or the tympanic membrane, and the graft that's usually used is the temporalis fascia. Okay. Then in type 2, we are going to place it over incus. So malleus ho gaya, now we go to incus. Type 2 is where the tympanic membrane graft is over the incus. So pehle pe malleus, then incus. 3 is, third letter is C. So this is columella tympanoplasty, where you are putting it on stapes. So also called as myringostepidiopexy, right? You are fixing it on the stapes, columella. 4. Now what can I do? So this is what is called as round window shielding or cavum minor, where the oval window has been exposed. So the graft is placed over the oval window, but the round window is kept open so that that shielding difference exists. That's why it's called as round window shielding. What is the shielding effect? The phase difference that we were talking about. So shielding or cavum minor. Type 5, now we have nothing left. So what do? We make a fenestration over lateral semicircular canal. We are trying to create a new window. So this is where we are making a fenestration in lateral semicircular canal. So what are the classes? Malleus, incus, stapes, also called as columella. This is cavum minor round window shielding. This is lateral semicircular canal fenestration, right? So these are your ossicular prosthesis. So look at the first one. This is what is called as TORP, total ossicular reconstruction prosthesis. So this is where only the stapes foot plate is present. So this is what will replace the effect of malleus, incus and the stapes. So directly put this on the foot plate. But you can see this is what will only replace malleus, incus. So this is what is POR, partial ossicular reconstruction prosthesis, and this is where only malleus and incus are not there. So this is about tympanoplasty. So now we've fixed the middle ear. Let's talk further. So now let's talk about how did we reach the mastoid. So do you remember that we had reached through posterior tympanotomy, and that is what was called as canal wall up procedure. So that we have already done. So this is where I am not removing external auditory canal wall. But the problem when you do this, obviously it's minimally invasive. So higher residual, higher recurrence disease. So what is more invasive? Just remove the posterior wall of ESC. You are creating a common cavity between mastoid and the ear. And now the problem with that is you cannot swim. Minor problem. Water tolerance is poor. Hearing aid will be hard to fit. right? So this is the disadvantage. Here we have two things. Canal wall down surgery could either be radical mastoidectomy or modified radical mastoidectomy. When I say radical, they preserve only the stapes foot plate, everything else is removed. Whereas in modified, you save all the ossicles. So you're saving the conductive pathway. All right. So what is the indication of modified radical mastoidectomy? MRM. Please don't think mastectomy. Okay. So MRM, this is also called Schwartz procedure. Any mastoiditis, acute otitis media we have to drain, or endolymphatic sac surgery or decompression of facial nerve. Radical mastoidectomy is where I will have a tumor, residual cholesteatoma hai, glomus tumor hai, carcinoma hai, we cannot leave behind anything, right? So this is what you will remember, simple cortical mastoidectomy versus radical, right? So these are a few terms which are confusing. They have asked you these indications multiple times, okay? So when to open up the mastoid, mastoiditis hai, pus hai, reservoir sign, or you want to go inside for either endolymphatic sac or facial nerve decompression. What about pinna reconstruction? So we don't do this before 5 years. This is done after 5 years because till then the pinna reaches the adult size. So this is where you will use costal cartilage from the ribs to construct the pinna. So this is indicated in anybody who doesn't have external ear, anosia or microtia, right? So we have fixed the external ear, we have fixed middle ear, we have fixed the mastoid, right? So this is what we have to learn so far as external and middle ear are concerned. Now what we are going to go about is an approach to hearing loss. So what are the different tests of hearing loss? Let's do an exhaustive approach here. So here pinna reconstruction. So let's say somebody does not have an external ear, microtia or anosia. We can use the costal cartilage autologous graft from the same patient to reconstruct it. But this is done after 6 years because the pinna will reach the adult size, right? So then you fix it. So this is about the management of the external part of the ear and the middle ear, right? So now we go into an approach to hearing loss where we learn the tuning fork test and the various investigations. Very, very important. So when we talk about the tuning fork test, let's learn the Rinne's test first. What is Rinne's test? See, first of all, you have to understand how are you hearing this talk? Through the air conduction pathway, right? The conduction is happening from external ear via your ossicles, your oval window is vibrating and your organ of Corti are conducting. So nature ne jo banaya is the best, right? So that's air conduction is always better than bone conduction via the mastoid. So now I vibrate a tuning fork, I keep it here near the air conduction. When the patient says I can no longer hear it, I place it on the bone conduction. Should I hear anything? No, because air conduction was better than bone conduction. Or you can invert it, pehle bone pe rakh lo, when you stop hearing, keep here, you should hear. So essentially I'm saying Rinne's positive is normal, that air conduction is better than bone conduction, isn't it? Or can I say that it is SNHL? Essentially, all I can say, it's not conductive because in conductive hearing loss, if nature's pathway is broken, now I'm going to hear better via bone conduction. So that's what is the interpretation. But false negative, if there is severe SNHL, right, that too unilateral. Now what will happen? I'll see a false negative Rinne's because now if one side cochlea is not working, there is transcranial conduction of the sound. If I stimulate the mastoid bone conduction, say cochlea stimulate hoga and transcranial conduction hoga. So it's okay, just remember false negative. That means now I have two options for both. Positive है तो या तो normal है या SNHL है. Negative है, most likely conductive, but one possibility severe unilateral SNHL. Okay, so that's where I am at, telling me that Rinne's is not that great because I have two possibilities. So now always that means they will give me Weber's as well. What is Weber's? Vibrate the tuning fork, keep it in the center. If I am normal, it should be no lateralization. I should not hear on any side. But if there is lateralization, means there is a problem. So this is very useful. Here you remember cross mnemonic, right? S is C, C is S. So if you hear on the same side, it's conductive hearing loss, contralateral SNHL. This is perhaps the most useful cross mnemonic, okay? So S is C, C is S. So this is how they will give me Rinne's, they will give me Weber's, and I'll manage to distinguish. Okay. Now, what I have to remember here is just one more aspect. What did we learn? That in SNHL also the bone conduction is what is decreased, right? So I've never find that out in SNHL bone conduction is decreased because I see that air conduction is better. So can I now compare with an examiner or an apparently normal person, and I will find that in SNHL ABC, which is absolute bone conduction, and Schwarzbach test, essentially testing the same thing, I will see that the bone conduction is reduced. When I put the tuning fork here on the mastoid, I'm checking the bone conduction. So let's say I stopped hearing and now I put it on the examiner, they shouldn't be able to hear. Or put it on examiner first and then on yourself, you should be able to hear. So this is where I'm isolating and saying your absolute bone conduction is decreased. On similar lines, there are two tests which are for conductive hearing loss. So Bing test is negative. What am I doing in Bing test? I am opening the external auditory canal, right? Basically, I am blocking external auditory canal and blocking air conduction, opening it again. Do you think in conductive hearing loss it matters whether you close it or open? They are not going to hear either ways. So that's big test. There is no difference. Whereas a normal person will say, when I closed it, I am not hearing it well. Try it. Close it and hear this lecture. It will decrease. But for a conductive hearing loss, it will not. So you are testing yourself right now. Gale's test negative particularly is for otosclerosis. Again, I use a Siegel speculum, change the pressure. Again, the hearing will change in a patient who's normal, but somebody whose stapes is fixed. Anyway, Siegel's is not going to change anything, right? So that's why that's negative, that there will be no change in their hearing loss. It will be bad. Okay, so these are, so in short, you remember ABC Schwarzbach, SNHL. Binget-Gell's negative in conductive hearing loss, and Gale's test negative particularly for otosclerosis. Okay, here I want you to remember this. This was asked previously. So tuning fork test, how much airborne gap can it distinguish? First of all, what is airborne gap? Can I say in conductive hearing loss, there is a discrimination between the two where air conduction falls? Yeah, but in SNHL, both are affected. It's bone conduction which is affected essentially, right? So this is airborne gap. So essentially the negative Rinne's that you are getting, if you are getting only at 256, the hearing loss is 20 to 30. If you are getting it 5 and 2, that goes without saying that 256 will be negative. That's 30 to 45 decibel hearing loss. And if you are negative at even 1024 hertz, provided all the three, when I say 1024 is negative, all three are negative, the hearing loss is maximum. So higher the frequency, higher the hearing loss. That's how you remember it. So this is what is the meaning of air-bone gap. Let's do some questions now. So what is the degree of hearing loss? This is what was asked. So tympanic membrane perforation alone leads to a 10 to 40 decibel hearing loss. Complete obstruction of ESC, headphones is complete obstruction, and when you have ossicles getting destroyed but tympanic membrane is also gone, here I will have a hearing loss of 40 decibels. But look at what is ironical. Tympanic membrane is intact, but the ossicles are destroyed, higher hearing loss. So when this is also damaged, lesser. But when that is intact, now the hearing loss is 55 decibels and maximum is complete stapes fixation, which is otosclerosis, 60 decibels. So remember in this order. Let's do the WHO classification of hearing loss. Here you have to remember everything. 0, 1, 2, 3, 4. Degree of hearing loss, description. Right? So imagine I am whispering at you from 1 meter. So if you are standing 1 meter and I'm whispering and you can hear it, there is no impairment. Right? So the hearing loss is less than 25. No impairment. If you are able to not hear the whisper, then you say, ma'am, please talk normally. If I talk normally and you are able to hear, that is slight impairment. You are saying, ma'am, I can't hear, please shout. So when I have to shout from 1 meter and you are able to hear, moderate impairment. You can't hear shout also. So I have to come inside your ear and shout. So if I shout in your ear and now you can hear, you have a severe problem. And you can't hear that also, you have a profound problem. So no, slight, moderate, severe, profound. Just speak this one more time and you will be good to go. Then remember the number 25 to 40, 40 to 60, 60 to 80, more than 80. So it's 20, 20, 80 से 60, 60 से 40. Now make it 50. Okay, so that's all. पहले 20 decline, then 15 decline. Okay, the tolerable sound level is at 90 decibels. Beyond 90 decibels, it becomes intolerable. Tympanic membrane rupture is said to be beyond 150 decibels. So this is where we will now talk about noise-induced hearing loss also in a bit. So this is about all of the numbers and they have asked this. Okay, so this scale is very important. So now we talk about pure tone audiometry, right? So the moment you've done your tuning fork test, the next step is to figure out whether it's a conductive hearing loss or SNHL. So we've already done that on the tuning fork, but just to confirm, we'll do something which is called as pure tone audiometry, where we document how much is the decibel at different frequencies. Now this also, like tuning fork, is a subjective test. That is important because this is where the patient will tell how much they are able to hear. So this is what is subjective, it's not an objective test. So first of all, this is what it'll look like. Understand the color coding. When it is red, ra se red, ra se right. Okay, on the other hand, if it is blue, it is the left ear. So first of all, I can see looking at this graph that it's showing me the left hearing. Now you see a gap, right? Here there is a legend which is given, but I'm telling you, you don't have to see that. Why? Because whenever there is a gap between air conduction, bone conduction, what do you think will fall? This has to be a conductive hearing loss when there is a gap. And you know, conductive hearing loss is air conduction worse. So it has to be this being air conduction, this being bone conduction, right? So either there is a gap or there is no gap. If there is no gap, it doesn't matter. If there is a gap, it is conductive, and who is going to be down? It's going to be air conduction. So do I need to confirm that with the legend? You don't. So please don't memorize the symbols. Okay. So this is what is called as air-bone gap. And whenever there is an air-bone gap, I can say this is conductive hearing loss. So what do I say for this patient? That this patient has left-sided conductive hearing loss and this is the gap. Let's say his right ear looks something like this. What would that be? So this is where you are seeing both air and bone conduction are low, both have fallen. So then I will say that this right ear is SNHL. And what would be normal? Normal would be where both are in this range. So that becomes normal hearing. Do you get it? So no gap, SNHL or normal. Look at where they are. Gap, conductive. So now look at this PYQ, wonderful PYQ. So first of all, what are you seeing? Without any knowledge of legends, can you say that this is the right ear and there is no gap between the two lines? Means right ear here is normal. What about the blue line, which is the left ear? I can see that there is no gap and both of these lines have fallen. So I can say this is left SNHL, right? So now they've asked me about what would be the tuning fork test. So what is the SNHL? SNHL is where Rinne's is going to be positive, right? So now what would be the Rinne's test? So remember what was positive? Positive was either normal or SNHL. So Rinne's is going to be positive. So I have two options. Weber's. What was Weber's? Cross mnemonic. S is C. So contralateral side. So Weber is going to be lateralized to the right ear. So this becomes the answer. So it's a wonderful question. We'll check your Rinne's, Weber's and pure tone audiometry knowledge at the same time, right? So that's what we are learning. Then we look at some more pure tone audiometry curves and try and make a diagnosis. They love to ask this. Okay, so what we have to see are the patterns in these diseases. So look at the first one. This is where you can see that it's SNHL for sure because both curves are together, and I can see it's bilateral. And what is it? It's a high frequency hearing loss. So whenever you have a high frequency hearing loss in bilateral ears, this is most likely presbycusis. Okay, so this is age related hearing loss. It's a sloping down sloping curve, high frequency. That's presbycusis. On the other hand, when you see that there is one notch that I am seeing, right? So it's not the graph falling, but I have a specific notching at 4000 Hertz. What is this? This is what we call as Boiler's notch. So Boiler's notch is a notch at 4000 Hertz. right? And this is what is indicative of noise-induced hearing loss. So noise, what does it affect? Outer hair cell, right? So this is outer hair cell damage, high frequency hearing loss, right? So two high frequency things I saw, presbycusis and a notch is Boiler's notch. Now look at this curve. What are we seeing in this pure audiometry? So we saw presbycusis, we saw Boiler's notch. Look at this curve in detail, and I am saying that there is a notch at 2000 hertz, right? So this is a notch at 2000 hertz. This is what we call as the Gerhardt's notch, very commonly asked. Okay, so this is one sure question that they always ask. This is a notch at 2000 hertz in which conduction, air or bone? So whenever I see a gap, what has fallen? Air has fallen. This is bone conduction. So 2000 hertz notch in bone conduction with a air bone gap. This is conductive hearing loss. And what is the diagnosis? Correct. We are talking about the most important disease, otosclerosis. So this is otosclerosis. Now, what all are you going to see here? Paracusis. What is paracusis? This is where we have a paradoxical hearing. The hearing becomes better in noisy environment. So these are people who hear better in noisy environment. Pregnancy, this aggravates. We are going to have bilateral gradual conductive hearing loss. What is happening essentially? Otosclerosis, also called as otospongiosis, which is a better name because this is where we are having too much remodeling of the bone, because of which the stapes foot plate gets fixed to the oval window, and the earliest site where it happens is just anterior to the stapes, that's called fistula antefenestrum. So this is essentially stapes which is fixed, hence not allowing conduction to happen, bilateral gradual conductive hearing loss. This is associated with osteogenesis imperfecta, that's also bone remodeling defect, right? So OI plus I can write otosclerosis is van der Waals syndrome. Very potential question. Schwarzschild was asked, this is salmon pink color that we can see through the tympanic membrane, which suggests that the disease is active. And if the disease is active, we can treat it with sodium fluoride, which will prevent the remodeling. So in an active stage, when you're seeing Schwarzschild, we can try sodium fluoride. Remember, don't use sodium fluoride in pregnancy, right? So this is contraindicated in pregnancy because the baby's bones are forming, right? We don't want to stop their remodeling. That's why. So what is the treatment if it's not active, if it's already fixed? So we can do two things. Either we can open up, so if possible we will do stapedotomy if we can release it. If not, you will have to remove it. So if this is not possible, we do stapedectomy and you replace it with this prosthesis. So what looks like this question mark is a post-stapedectomy prosthesis, right? So this is about otosclerosis. So 3 graphs done. Falling curve, which was presbycusis, noise-induced hearing loss, 2000 hertz, otosclerosis, Gerhardt's notch. Now look at a rising curve. So this is where the hearing loss is more in the low frequency. So low frequency, rising curve. This is what is seen in Meniere's. So in early Meniere's disease, we are going to see a low frequency hearing loss. What is Meniere's? In one line, remember, endolymphatic hydrops. So this is where we are having too much endolymph in the inner ear. What is the hearing loss? Remember this pattern, opposite of otosclerosis. There is bilateral gradual conductive. This is unilateral episodic SNHL. Not just SNHL, tinnitus, vertigo, SNHL, TVS. What is Lermois? It's a reverse Meniere's. This is where SNHL is then going to be progressed by tinnitus or vertigo. So this is reverse Meniere's. This is called Lermois syndrome. Then what else do you get in Meniere's is diplacusis. 2 frequency sounds will be heard. Then Tulio-Tumarkin. These people don't like parties, whereas otosclerosis loves parties. Why? Because they hear better in noisy environment. These guys hate party because what will happen? Any loud noise will increase their vertigo. Not just that, they will fall. They will have drop attacks called as Tumarkin phenomena. So any loud noise leading to vertigo, drop attacks, because the endolymphatic sac is distended with fluid. The moment a loud noise strikes, they'll have, they'll get irritated and they'll have drop attacks or vertigo. The investigation of choice has been asked. This is electrocochleography. It's a cochlear issue, right? So this is electrocochleography. So normally we take this ratio. This is what electrocochleography looks. We are monitoring the voltage. I have this summating potential and this action potential. So SP upon AP normally should be less than 30%. So if this ratio increases, so in Meniere's they see that the ratio increases, so SP by AP typically becomes more than 45%, and that's diagnostic of Meniere's disease. How to treat it? So there are variety of things that you can do. So initially you will do conservative measures where you remove all the good things in life from them. You remove caffeine, you remove alcohol from their diet, right? You give them antihistaminics, you can try, right? You can also try steroids. Okay, so after using all of these, if it doesn't resolve, there are a few more options. We can use a Menet's device. It's a pressure regulating device in the ear. You can do endolymphatic sac decompression. There is a landmark called as Donaldson's line for that. That has been asked. And the last resort is kill the ear. If nothing is working, just kill the ear. Hearing loss anyways was there. At least now you will not have tinnitus or vertigo. So what are we doing? We're putting a microvic right into the inner ear. Where do we do that? Scala tympani. Exactly where we put cochlear implant electrode also, which we will learn. So we put an electrode, a microvic in scala tympani, and you know what we are putting? We are putting gentamicin inside, an ototoxic drug inside the ear. So this is your end stage where nothing is working. Kill the ear, right? So this is what is Meniere's disease. Then look at this graph here. It looks like a mid-frequency hearing loss. This is what is called as a cookie bite audiogram or a U-shaped audiogram, and this is something that is seen in congenital hearing loss. Okay, so 5 PTA curves you have seen. Let's revise. 4000 Hertz, noise induced. 2000, otosclerosis. Falling, presbycusis. Rising, Meniere's. And mid-frequency, that's congenital, right? So that's about this page. So now we have more tests. So you've done the pure tone audiometry. Now we go on to either conductive or SNHL. So through PTA now you have learned whether it's conductive or SNHL. So the investigation of choice, if it turned out to be conductive hearing loss, is going to be impedance audiometry, right? So this is what is impedance audiometry, and it includes two things. So here impedance audiometry is going to have this one component which is called as tympanometry. As the name suggests, I'm studying the middle ear and I'm going to study the stapedial reflex. Okay, so both of these are parts of the impedance audiometry study. So now in tympanometry, we have this probe or this transducer that we place in the external auditory canal, which has three jobs. One, it is going to send a sound which is a 220 Hertz tone. It will pick up the sounds that are coming from the ear, and it will also measure the ear pressure changes, right? So these are the three things done by this transducer: send, receive, measure ear pressure changes. So this is the curve all of you know very well. So these are the pressure changes that we are seeing of the inner ear. So these are the pressure gradings. So look at this curve A. This is what is normal. When it is a very high graph AD, this is what indicates ossicular discontinuity. So this is ossicular discontinuity. AS small curve, because the stapes is fixed. AS for otosclerosis. Okay, so that's small, sclerosed. Look at C. This is what is peaking at a negative pressure, right? So here the center has shifted to negative pressure. Why? Because the eustachian tube is not working. So this is ET dysfunction, or I can say a retracted tympanic membrane as a result. What is B? B is a horizontal curve. Remember how in radiology I have taught you that whenever you see this air and fluid making a horizontal level, that is fluid, isn't it? So here horizontal curve B indicates fluid. So what is B? This is serous otitis media or glue ear. So this is how we interpret the tympanometry curves, and through this have you found out the cause of conductive hearing loss, whether it's otosclerosis, ossicles destroyed, tympanic membrane because of eustachian tube, or glue ear, right? So this is what we need to remember. One more cause you want to remember, which you will instinctively think is SNHL, but it's not. Superior canal dehiscence actually leads to conductive hearing loss. So do remember that. The other component was testing the stapedial reflex. So stapedial reflex, you know what happens? The afferent. Afferent is the ipsilateral eighth cranial nerve, right? I'm just about to teach you the auditory pathway. I will tell you that there it goes to superior olivary nucleus. So this is where now it sends bilateral stimuli and the efferent becomes seventh cranial nerve bilaterally, right? So this is ipsilateral, whereas at superior olivary it now goes to bilateral, much like Edinger-Westphal. You remember? Bilateral meiosis will happen. So bilateral stapedial contraction will happen. So any loud noise goes to the eighth cranial nerve, goes to the seventh cranial nerve, gives supply to nerve to stapedius. The stapedius contracts and dampens those loud noises. So that is the job of the stapedial reflex, to dampen loud noise. And if this does not work, I am going to have hyperacusis, right? There is no dampening. All the sounds sound very loud. So that's hyperacusis. Okay, so this is stapedial reflex. Now let's study cochlear versus retrocochlear. So let's say your result came out to be SNHL. So now what we have to do are these speech audiometry studies, and they will tell us whether it's cochlear or retrocochlear. So I'm going to tell you the buzzwords, right, that you have to hear. So this is what is a part of speech audiometry, where we quantitate how much are they able to understand and hear. So speech audiometry curves, very, very important. So look at this. This is normal, same curve, but at a higher amplification means they hear lesser, is conductive hearing loss. Look at this. So in cochlear hearing loss, as we keep increasing the amplification, they improve, but after a point it reaches a plateau. So this plateau is retrocochlear. Retrocochlear, what we see is it increases and then it just dips if you go on louder. So that's retrocochlear. And RO, this is what is called as rollover phenomena. So they love this question, rollover phenomena, which I am seeing is this dip is retrocochlear. So remember the graph, this is very potential, not been asked so far. Okay, so rollover phenomena. Then you will remember the other buzzword for retrocochlear, speech discrimination. Means they are hearing but they are not able to differentiate similar words or sounds. So speech discrimination poor hai. Apart from that, you will be able to figure out any nerve related thing. Tone decay, stapedial reflex, eighth cranial nerve. What is the meaning of retrocochlear? Eighth cranial nerve. Prototype being vestibular schwannoma. Cochlear prototype being Meniere's, right? Any cochlear cause. So this is Meniere's. So this is about retrocochlear, where rollover, tone decay is present, stapedial reflex is abnormal, speech discrimination is poor, and BERA is the investigation of choice, which will tell us about all of the conductive pathway and hence the nerve, right? Cochlear lesion, what are the features? SISI, what is SISI score? So this is, SISI is short-term increment in the sounds. With short-term increments, how well are you able to hear? So they are able to hear very well. It's abnormally high. Means when you are talking normally, these patients will tell you, I can't hear you. The moment you increase your volume, they will be like, why are you shouting? Okay, so their abnormality, the increment is very, very high, right? So that's how they'll behave. Then it is called as alternate binaural loudness balance. Please don't even bother. So this is what is essentially the phenomena in cochlear lesion, which is recruitment. So what is recruitment? Same thing. Abnormal growth of perceived loudness with increasing sound intensity. Means this curve of increment is very high. Can you see that this curve is very fast growing? So that's what is recruitment or SISI score high. So remember the buzzwords for cochlear and retrocochlear lesion, right? So cochlear will remember SISI and recruitment, retrocochlear roll over, discrimination poor, right? So this table I feel has the potential to get asked, and that's a differentiator. Okay, let's do more tests. So now we have two tests which are objective tests. Okay, so the first one is autoacoustic emissions. So we have this monitor in this child's ear and we are trying to see if autoacoustic emissions are coming or not. So there are spontaneous OAEs which are emitted by who? By outer hair cells. So 3-letter of OAE, 3-letter of outer hair cell. So they are emitted by OHC, but the spontaneous ones may be absent in 50%. So I cannot diagnose hearing loss on that basis. So that's why what we use are transient evoked autoacoustic autoacoustic emissions. So we give a stimulus and then we see if they are getting produced or not. So what is the pathway? Outer hair cell will produce. They were on the basilar membrane via perilymph through the oval window, through the ossicles, tympanic membrane, ESC. So it's the reverse pathway of sound, isn't it? So just from this direction, how does sound travel? External auditory canal, tympanic membrane, ossicles, oval window, perilymph, basilar, OHC. So just do the opposite. That's the order in which we are picking these autoacoustic emissions. So this is what is the screening test of choice. This should be done in all babies before discharge, but at least by 1 month it should be done in every baby. So this is screening in all, because how will you know whether a baby can listen or not? By the time they can tell, it will be too late. They won't be able to tell, because no speech will develop if they've not heard sounds, right? So screening in all babies, right? So this is autoacoustic emission. Let's say autoacoustic emissions were not found. Don't directly go to confirmation. You will clean the ear wax once. Maybe it's because of the ear wax or any gelatinous membrane. Remember, we see in preterm there's this Redden's membrane. We had learnt in stillbirth. But anyways, in preterm membranes or anybody, if they have any fluid, we may not be perceiving it. So that's why clean the ear and repeat it. And after that, if it is still not heard, now what is the confirmatory test? That is BERA. So confirmation is with BERA, brainstem evoked response audiometry. So you can see there are a lot more monitors that I am seeing here. What are the different waves of BERA? So for this you will remember the auditory pathway. We will revise it simultaneously. So we remember E colima, right? So E colima is what I have to hear. So what are the different waves? 1, 2, 3, 4, 5, 6 and 7. So there are 7 BERA waves. A is auditory cortex, so that's not brainstem, right? So 7 BERA waves. Who makes it? So E and E are the 8th cranial nerve. So spiral ganglion form the 8th cranial nerve. Then it goes to the cochlear nucleus. Then it goes to superior olivary. Remember, this was the center where now it goes to bilateral facial nerves. Then I have very important lateral lemniscus. So if they ask which is the most important BERA wave 5 emitted by lateral lemniscus. Then it goes to inferior colliculus and then medial geniculate body. Inferior, your ears are inferior, eyes are superior. So superior colliculus is for light. M for music, this is thalamic nucleus, medial geniculate. L for light, lateral geniculate, right? So correlate the two senses. And A is the auditory cortex, which is what area? So this is what Broadman area? So this is Broadman area 41. Remember, I have told you 41 ki age pe you hear about a restaurant, then go to taste it at 43, right? So this is 41. So this is the auditory pathway and the BERA waves. Okay, so here you want to remember a rule of 369. We have studied in radio obstruction 3 cm, 6 cm, 9 cm, small bowel, large bowel, cecum. We have studied in ortho also 369. What did we study? Callus will be formed by 3 months, delayed union is 6 months, non-union is 9. So this is the third one. Screening by 1 month, confirmed by 3 months. The hearing aid, the rehabilitation should happen as soon as possible. So that's usually by 6 months, and cochlear implant is minimum age cochlear implant can be put as 9 months. So 3, 6, 9. Some people write 1 year, but it fits 3, 6, 9. So 9 months is a better answer here. Okay, so this is about BERA. BERA, I told you, is the investigation of choice for retrocochlear hearing loss. And what is the prototype disease for retrocochlear? It's vestibular schwannoma. So now let's just study vestibular schwannoma here. Very, very important. So this is where first we need to learn the RAD path, right? Investigation of choice is going to be contrast enhanced MRI. So you're going to be doing a contrast enhanced MRI. Look at this part of the brain. So this is the cerebellum, this is the pons. So this is a tumor. In fact, this is the most common tumor of the CP angle. cerebellopontine angle. Can you see this lesion? This is where it grows here in the CP angle cistern, and now when it enters into the internal auditory meatus, it tapers. So this is what is called as an ice cream cone appearance, right? That in the meatus it tapers and it grows in the cerebellopontine cistern. Okay, so this is the radiological appearance. Pathological appearance, you see these two areas. This is the cellular area, which is Verrucke bodies, right? So these bodies constitute the cells. So this is antennae A, whereas the acellular area is antennae B. So this is what is vestibular schwannoma. The most common nerve which is affected here is the inferior vestibular nerve, alright. So this is the inferior vestibular nerve out of the vestibulocochlear that gets affected. How do we treat it? So here you have to look at the size, very important. So if it is less than 3 centimeters, then we can try gamma knife. So this is now becoming the first line preferred treatment option. So less than 3 centimeter, we will try and do gamma knife, right? So gamma knife is something which is the first line treatment, all right? So you will give focused radiation to the tumor, and that is what is the first line. Any mass which is more than 3 centimeter, what am I going to do? Then the surgery becomes the first line, right? So it's then going to be surgery, because then gamma knife won't be enough to remove this tumor. So this is what I have to understand here. Very important association is NF2. So bilateral vestibular schwannoma is diagnostic of NF2. If it is unilateral, we will look at family history, okay? So if family history is positive, it becomes NF2. So association, very important, neurofibromatosis too. Fine. So this is what is about vestibular schwannoma. Few more miscellaneous points about what ototoxic drugs will do. Alright, so ototoxic drugs, remember, first of all, let's talk about aminoglycosides. All aminoglycosides will attack the cochlea except GST. So what is GST? You know, you will pay this GST tax now as you keep earning more and more. You'll have to pay 18% GST. Okay, on a lot of goods also you pay 18% GST. So what is GST? इतना GST pay करेंगे चक्कर आ जाएगा. Vestibulotoxic. So that's how I will remember GST drugs. So gentamicin, streptomycin and tobramycin. So these are the drugs which are vestibulotoxin. So through this now I can remember all the rest of the aminoglycosides are going to be cochlear toxic, right? So that is what is GST. All right. Apart from that, what are the drugs that affect stria vascularis? So remember two class of drugs. This is where one we have diuretics. Okay. So how I remember this is stria vascularis was making endolymph. Diuretics decrease fluid. So diuretics attack stria vascularis. You know, mainly loop diuretics, and here also we learn there is something called as ethacrinic acid, which is the most ototoxic, right? So this is what is the most ototoxic loop diuretic. That's why we don't prefer to use it. So diuretics are one class and the other class is quinine and its family. So what is the family of quinine? We have quinine, we have hydroxyquinine, and you have colchicine. So all of the quinine class of drugs also attack the stria vascularis, right? So can I say everything else is cochlear toxic? Yes, you can. So particularly which other drugs are cochlear toxic? We have aminoglycosides, we have vancomycin, we have cisplatin, and we have macrolides. So don't remember this list. Why I never wrote this? This is cochlear toxin. We ignore this because I remember GST is vestibulotoxic, chakkar aayenge, and stria ke two categories. So everything else is cochlear toxic, right? So that's how you can remember the ototoxic drugs. And again, who do they attack? Outer hair cell. So no matter what they ask, who is making otocaustic emission, who is ototoxic drug attacking, what is noise attacking, all the answers are going to be outer hair cells. All right, so this is what we have to remember here. Now let's talk about the vestibular function test. So this is the part which I always hated to study, but now they're asking more and more questions from this, so we have to go in a little bit of a detail. Okay, so first of all, let's understand the causes of vertigo. It could either be peripheral vertigo, which can be explained by the inner ear and the vestibular system, or it could be central vertigo, which is because of brainstem issues, cerebellar issues, right? So this is inner ear. How to remember this is very easy. If you want to go to a central institute, you want to crack INICT, how do you have to study? Should there be a latency that you have woken up, wasted 2 hours, then started studying? Can't be. No latency. Do you have to study for more than 1 minute? Clearly. So more than 1 minute. Any direction that I put you in, ulta latkaya, seedha, transverse, you are studying. Any direction changing, you have to study. Will you get tired? Non-fatigable. So how to get into Central Institute? No latency, more than 1 minute, changing direction, non-fatigable. So anything else, peripheral. So what is peripheral? 2 to 20 second का latency है. Lasts for more than 1 minute. Direction is fixed, fatigable hai, and there can be vertigo as well, right? Apart from that, look at two more buzzwords. So suppressed by optic fixation. That can't be in Central Institute. If you see somebody very, very beautiful, will you sit and stare at them or will you study? You will study. So no optic fixation, suppression of studies, okay? And then, is it enhanced in darkness? No, you will study whenever. Your study will not be enhanced in darkness. You will need light, okay? So it is not enhanced in darkness or these Fresnel glasses which enhance peripheral vertigo. Okay, so we just remember what is it that is needed for a Central Institute, right? So this is about the vertigo. So this is about the difference. Now let's do few more tests. So let's do this. So this is what is called as a bithermal caloric test, also called as Fitzgerald-Hallpike test. Okay, so this is where you are going to send into the ear two temperature. One is cold, one is hot. Cold is 30, hot is 44. You are lying down in a table with 30-degree tilt. Okay. What is normal is cows. Okay, so don't think cows is abnormal. Cows are normal, right? So what is cows? When you put the cold temperature, 30-degree, the nystagmus is in the opposite direction. I will talk about that. When you put warm water, it is in the same side. So this is normal. If it is not happening, that means there is an issue with labyrinth. So this is where if there is a dead labyrinth, I'll have no nystagmus. Now, what do I call as nystagmus direction? So nystagmus will have a fast component and a slow component. What is the component that I count? Always the fast component, right? So we count the fast horizontal component. So if I'm putting fluid in the right ear, what should I see? That the nystagmus is going in the left side in cold water, so that is what the side means, opposite, same. So remember cows, and remember the direction that I always count in nystagmus is going to be fast component, horizontal component. Now let's talk about fistula test. So what we check in the fistula test is we use the Siegel speculum to change the pressure, and if that Siegelization, changing the pressure, is getting transmitted to the inner ear, that will cause us to have inner ear symptoms like vertigo and nystagmus, right? So if there is a fistula, what are the conditions where we have a fistula? Erosion हो गया, horizontal semicircular canal. You have performed a fenestration surgery, remember, type 5 tympanoplasty, or there is a post-epidectomy fistula. So there's a real fistula and you are having this. But what will be asked are these, right? False negative, that there is a fistula, still no nystagmus. Two possibilities. One, there is a dead labyrinth. No matter what happens, now you are not going to have fistula. It's over. Or two pathologies are there. There is a cholesteatoma which is covering the fistula. So there is a cholesteatoma that is covering the fistula. Okay. On the other hand, false positive fistula means there's no fistula, still nystagmus happened. So one is Meniere's. Remember, they were having nystagmus and vertigo even on loud noises. Yeah, Tullio phenomena. So obviously on Siegelization they'll have. Or it could be congenital syphilis, where the stapes is hypermobile. So this hypermobile stapes will keep moving. It will open up the oval window and that can result in vertigo, right? So this false positive is called as Hennebert sign. What was Hitzelberger sign? That was seventh nerve. Remember first page where we studied seventh nerve, vestibular schwannoma can affect and result in posterior wall and floor ka sensation loss, right? So this is what I have to remember here for fistula test. Now let's look at this. So you can also have VEMPs, which are vestibular evoked myogenic potential, which can be cervical or ocular. So cervical VEMP, remember so say so. I want you to focus on S. Comes from saccule, goes to inferior. यहाँ पे S नहीं है. Inferior vestibular nerve, vestibular nuclei, spinal tract, 11th cranial nerve, sternocleidomastoid. So this is how the vestibule relates to my head turning, sternocleidomastoid, mediated through saccule. My eyes also, what is the vestibulo-ocular reflex? For example, I ask you that you have to keep seeing at the screen and change your head. So basically what is happening is my eyes, my vestibule and my head or neck are in one synchrony. So this is mediated by the vestibule. So this was the neck part, now the eye part. So this is mediated by utricle, vowels stick together, goes to superior vestibular nerve, MLF's third cranial nerve and going to inferior oblique. Right? So you need to know these pathways, and can I say anytime the vestibular nerve is affected, which is either acoustic neuroma or neuritis, this will be decreased. So this can be diagnostic of nerve pathologies, retrocochlear pathologies. Okay. Then they had asked this question on head impulse test. This is exactly what I just told you. What will happen if I ask you to keep staring at the camera and look here? Look to the other side, right? So this is what is called as the normal head impulse test. There should be no nystagmus. But upon turning, if I have a quick saccadic movement and then it fixes, that is what is an abnormal head impulse test. So let me repeat, look at this. If I am doing head movement and my eyes always could maintain the fixation, this is normal. But upon doing this, if you had a contralateral eye movement, which was a saccade, right? If I had a contralateral eye movement, which is called a saccade, and then I could fixate, this is what is a positive head impulse test, where now I am having this corrective saccade. I could not directly fix. So this is positive head impulse test, and basically whichever direction I am looking, the head impulse test will be contralateral. It will be contralateral to the site of the vestibule which is affected. Alright, so this is what you remember, contralateral direction hoga. Whichever side neuritis, uske opposite side I will have this saccadic movement, and this is what we have to remember, and this indicates a peripheral cause of vertigo. Okay, so this is for vestibulitis. So just to clarify, this is what the previous year question came, so that you can understand. So if somebody has a left-sided vestibular neuritis, you have to rotate the head on that side, whatever side is the suspicion, right? And the saccade will be on the opposite side. So remember, jis side ka neuritis, try it on both sides. The saccade will be contralateral. Alright, so this is how we identify. So I hope this topic is clear. The buzzword is contralateral. Now let's do something super important. How do you approach vertigo? So we've figured out whether it's central or it's peripheral. Just on those lines, if somebody has acute vestibular syndrome, there is something called as Hint's exam. So what is Hint's exam? So this is where one is head impulse test. So if the cause is a central cause, right, the head impulse test will be negative. We just saw that. Then there will be nystagmus, and we will have test of skewing. So hint TS is test of skewness, and there is something called as vertical skew deviation. So vertical skew deviation, I don't want to go into the details, is something which will be positive for central. Nystagmus features, I've already told you how to distinguish central versus peripheral, right? So this we have already done about how the nystagmus would be. So using this Hint's examination, we'll know whether it's central or peripheral. Head impulse only in peripheral, vertical skew only in center, right? So that's one. So central versus peripheral is now figured out. So let's say I've reached a cause of peripheral nystagmus. It's the ear. Now what in the ear? What is the diagnosis? So there you follow this approach. Very useful for exams, okay? Whether there is hearing loss or not is what I have to see. So if there is no hearing loss, only vertigo. Now there are two possibilities. In first, the answer will be in the question only. Paroxysmal, positional vertigo. These are the buzzwords. Happens only in certain positions, comes and goes. So this is benign positional paroxysmal vertigo. Comes from the name, no hearing loss. The other cause is vestibular neuritis. Again, this is acute onset, right? So neuritis inflammation, acute onset, but it's not positional, it's not paroxysmal. So this is when you only have vertigo. Let's discuss BPPV. So benign positional paroxysmal vertigo ka cause is an otolith. So it's a stone, calcium carbonate stone that's stuck. The most common semicircular canal where it's stuck is the posterior semicircular canal. So this is where that stone is stuck. So how do I diagnose it? So DX is DX. So this is the Dix-Hallpike maneuver where this patient is sitting. So now you keep tilting him posteriorly. Basically, the concept is you are trying to get that otolith in a triggering position and you will have vertigo. So that is Dix-Hallpike to diagnose. But you don't just want to diagnose, you want to fix him also. This is where I'm removing the stone and treating the patient. So this therapeutic maneuver is called as Epley's maneuver. In Epley's, they can ask you these steps, okay, and the angles. So here, let's do this. So this is where, let's say this person is facing at 45 degrees, okay, lateral. Now what you do is you make him lie down by 45 degrees. So the angle that you have changed is 45 degree and his head is tilted backwards at 30 degrees. Okay, so they may put, so they can ask you 5 numbers to arrange. Okay, so it can either be 45 followed by 45 or 30s. Telling you both numbers because they can give you either. After this, so this is 1, 2, 3. Now you ask him to turn his head completely on the other side. So we did a 90-degree turn of his head. Now we again ask him to turn by 90 degree into lateral decubitus position, and then you make him sit down to its original 45-degree position. Okay, so this is how that stone will be removed. So I want you to remember the sequence: 45, 45, 90, 90 and 45. In between, they can give you 30 degree as the second one. Okay, so this is about Epley's. So we have done Dix-Hallpike, we have done Epley's, only vertigo, no hearing loss. What if there is vertigo with hearing loss? First of all, do you remember TVS? So if you have unilateral sudden TVS, you have diplacusis, Tullio, Tumarkin, what am I talking about? Meniere's disease. So you do electrocochleography, you treat it, we know it all. So that's Meniere's. What is the other DD? Fistula test came out to be positive. I was doing maneuver with Siegel's speculum and the patient had vertigo. So this is where there is a fistula. So this is a perilymphatic fistula. So how do I diagnose this? Using a fistula test. So that can also cause vertigo and hearing loss. And finally, most important, labyrinthitis. Okay, so labyrinthitis, inflammation of inner ear, again hearing loss and vertigo will happen. And very important, what kind of labyrinthitis? So remember, everything contralateral. Purulent labyrinthitis, traumatic labyrinthitis. This is called labyrinth is not working. Hypoactive. Where will I have nystagmus? Contralateral. So this is where, let's say I have right-sided labyrinthitis, my horizontal fast component of nystagmus will be on the left side. Yeah. The only place where it's ipsilateral is serous labyrinthitis or hyperactive labyrinthitis. Okay, so labyrinthitis, fistula, TVS, and for labyrinthitis, remember it's contralateral unless they mention hyperactive or serous. Okay, so this is, I feel, the last 3 slides that we have done are the part that students skip the most, and that's what they are trying to ask now. So please remember this clinical picture. Now let's talk about hearing rehabilitation, super important. So now let's talk about this particular image. They can ask you what is this. So this is where we are talking about Baha. What is BAHA? It is a bone anchored hearing aid. Okay, so for any hearing loss, the first line is always going to be hearing aid. What do hearing aids do? They're just like amplifiers. They're gonna amplify the sound. It's like a speaker. They'll increase the volume so that you can hear. If you can't hear through hearing aids, now if this is not working, now what do you do? So that's what we are trying to study, what to do if hearing aids don't work. So first is BAHA as the option. So that is bone anchored hearing aid, where what essentially you are doing is there is this audio processor that you are anchoring onto the bone, right, on the temporal bone. Because you are anchoring it, this is something which can be done beyond 5 years only, because we require that thickness of the bone, because this is integrated into the bone via osseo integration. The concept is stimulate the cochlea directly. So this is where you pass this implant, it goes and stimulates the cochlea directly through this sound. It is vibrating, stimulating cochlea. So the condition here is unilateral hona chahiye. If it is bilateral hearing loss, what is the cochlea stimulating? If it is unilateral, then the contralateral side cochlea will get stimulated, right? So that is why this is only unilateral hearing loss. Apart from that, the other indications could be any time I want to bypass this part, isn't it? So anybody who has external auditory canal atresia, it is filled with pus, or you have microtia, external ear is not formed, right? So in that case, I can use. Apart from that, you'll remember unilateral profound to severe hearing loss, I can use BAHA. So very, very important, bilateral hearing loss here is a contraindication. Okay, so that is very important. So what to do if one has bilateral hearing loss? In that case, if it's not responding to the hearing aids, obviously, now we go to cochlear implant. Very, very important. So look at this cochlear implant. You can see this is the speech processor and transmitter, which is like any other hearing aid attached outside, and we have an implant. So where does the implant go? You remember posterior tympanotomy. Through the posterior tympanotomy, you have the round window. So against the round window, what do I have? Scala tympani. So this is where that microvic was placed. This is where we shall place our cochlear implant into the scala tympani. This is the electrode that will stimulate the organ of cotti, right? So look at these parts. So 1, 2 and 3, this is what is the outer processor, right, that we have, and there is a magnet attached to it. So this is the processor. Number 4 is the reference electrode. This is what NEET 24 asked you, reference electrode, whereas this is the cochlear implant electrode that is going inside. So this is the intracochlear part where it's taking a turn. So what is very important is, if I stimulate the cochlea through this, I can, treat. But if there is no nerve, if it's a retrocochlear cause, I cannot treat it. So the nerve here has to be intact, and that's what is the prerequisite. Now, can I do it in Michel's aplasia? Michel aplasia is the most severe inner ear malformation where the cochlea is not formed. If there is no cochlea, where will I put the implant? So Michel's aplasia is a contraindication. Mondini's dysplasia is one of the most common indications. I can do in Mondini's dysplasia. This is where instead of the 2 3/4 turns, I only have 1.5 turns. Basically, the basal turn of cochlea is missing, right? So there's no basal turn of cochlea. This is where I can do a cochlear implant. Sheep's dysplasia क्या होता है? This is the most common inner ear malformation. This is what is a cochleosaccular dysplasia. Okay, so remember, Sheep's is most common, cochleosaccular dysplasia, whereas Mondini's is also very common. 1.5 turns are there. So both of these I can put a cochlear implant. CI and contraindication are the same spelling, so it may get tricky. So please listen to this and don't just read. So Michel, CI is CI. Mondini sheep, CI is not CI. I can put a cochlear implant. So I'm going to write the full form, can put cochlear implant. Okay, so this is about cochlear implant. If one does not have the nerve, what to do? Now I'll have to put the auditory brainstem implant. This is what is put in the fourth ventricle lateral recess, where it can directly stimulate the nuclei, the brainstem. Okay, so this is auditory brainstem implant. The last part that I have to define is what is sudden SNHL. So sudden SNHL is if we have a hearing loss of 30 decibels or more over three contiguous frequencies occurring within 3 days. So the buzzword is 3 times 3. 3 days may 3 frequencies, 30 decibels. How do we treat? So, just we can't do anything here. So we are asking the patient to do rest. You can try hyperbaric oxygen. When all fails, who do we go to? We go to steroids. You can try steroids trial, right? So all things we are trying out here for sudden SNHL. Most cases improve here, right? So the prognosis is good. So this is about the hearing loss and the ear aspect. So now let's start talking about the facial nerve. So the first thing we'll do is learn the course and where it gives the branches. So here you get, two kinds of questions. One would be topographical localization, that where is the injury. So you can know that on the basis of the branches that it gives, right? So we'll look at the different parts of the facial nerve and the branches that it gives first, and then you would have the second half, which is, where the injury happens and how do we localize it. All right, so this is in terms of UMN element, the second part. So let's talk about the course of the facial nerve. So as soon as it arises from the pons, seventh and eighth cranial nerve enter the internal auditory meatus. What are the parts of the internal auditory meatus? So very, very important. The horizontal bony bar is called falciform crest, and there is a vertical bar called as Bill's bar. So this is where the course is. Remember it as 7 up, coke down. 7 up, 7 up, coke down. Means 7 and up superior vestibular nerve are located upper superiorly and coke down. Cochlear and down inferior vestibular nerve are arranged below. So 7th cranial nerve is a mixture of both. So it's actually two nerves which go here. The motor part and the sensory part here, the smaller sensory part is called as nervus intermedius and can also be called as nerve of Risberg. So this is the sensory part. So what the nerve of Risberg or the nervus intermedius carries are two things. One is the taste and second is the secreto motor fibers, right? So you know that facial nerve carries the parasympathetic supply to the lacrimal glands via GSP and it carries the taste via chorda tympani. So both of these fibers run in the nerve of Risberg separately. So they're just two branches of the facial nerve, right? So this is what is our meatal part, the first part where it enters the internal auditory meatus, and this is where it becomes the fallopian canal, and now it is going to run in its own bony canal throughout. Now it enters the inner ear. So the second part is labyrinthine part. Very important. This is the narrowest and the shortest part. So because it's the narrowest part, any pathology here, let's say there is some pathology like a viral infection, the nerve will have edema, and this is where it will get trapped because it's a very narrow part here. So this is where you have the most common involvement in viral infections like HSV1. So this is what we call as Bell's palsy, right? So Bell's palsy is nothing but facial nerve involvement, and the most common part where that happens is the labyrinthine segment, right? So it happens most commonly here. This is where it's involved. HSV1 is what causes it. Usually it's idiopathic. So just remember Bell's palsy happens here while we're talking about Bell's palsy. So if you can diagnose it within 3 days, then we will start the patient on acyclovir. After that, it's not shown to have any benefit. But after that, or at any point of time, if they'll ask you what is the drug of choice, that happens to be steroids, right? Because it's edema. To decrease the edema, we'll give steroids. So that's about Bell's palsy. Then it takes a turn. So this is the geniculate ganglion. So this is where the geniculate ganglion corresponds to the first geno, and the landmark of the first geno is said to be processus cochleaformis. All right, so that is processus cochleaformis, which is nothing but what corresponds to the tendon of tensor tympani. You remember in the medial wall of the middle ear, we had seen the processus cochleaformis. This is where the tensor tympani forms a hook, right? So that is what forms the landmark for the first turn where it enters from the inner ear to the
middle ear, and this is where it gives off GSPN, very important, great superficial petrosal nerve. In ANAT we have studied this. जो लोग हमें great लगते हैं but they are actually superficial are the ones that make us cry. People who feel are great but are actually superficial make us cry. So that's what is responsible for lacrimation, as well as the mucosal glands in the sinuses. So mainly lacrimation. So this is where GSPN comes. Now it is entering the middle ear. So this is where you have the tympanic or the horizontal course, and this is in the medial wall, right? So where it takes the first geno, this is where you have the medial wall of middle ear, which is the horizontal part where it is present in fallopian canal, and that is the most common site of dehiscence. Then comes the second geno, the second turn where it becomes the vertical segment, and this is what is happening in the posterior wall of the middle ear. Do you remember this? So posterior wall of middle ear, this is where it gives off two branches. What are the two branches? One is the nerve to stapedius, and second is your chorda tympani. So nerve to stapedius का काम क्या है? We have already discussed this. This is where we have hyperacusis, which is dampened, right? So it dampens the loud sounds. So if this is not there, I'll have hyperacusis. And chorda tympani is what is carrying taste. Taste to what? Anterior 2/3 of the tongue, right? So that's chorda tympani. So both of these branches are coming from the mastoid or the vertical segment, and this is what can get injured during mastoid surgery when we are doing a posterior tympanotomy. So this is the second geno, the second turn, and the landmark for that is nothing but the pyramid, the pyramidal eminence, which is formed by the stapedius, right? So remember the two landmarks. So now the chorda tympani emerges through the anterior wall of the ear via the canal of Eugier, whereas the facial nerve runs vertically and opens through the stylomastoid foramen and gives the facial branches which supply the muscles of the face. So what are these branches? So you want to remember 10 zebras bit my cat. So the upper branch is the temporal branch. Then we have the zygomatic branch, the buccal branch around the maxillary sinus. Then we have the marginal mandibular branch. If injured, this can cause deviation of angle of mandible. This has been asked. And lastly, we have the cervical branch supplying the neck. So this is what are all the muscles supplied by the facial nerve, right? So this is about the parts. Now, if somebody is losing lacrimation, can I say everything else will be lost? So agar injury yahan hai, it is here. So if somebody is losing lacrimation, that would mean that the injury has happened in the labyrinthine segment, because this branch is also going. But if they say that lacrimation is intact but hyperacusis is there, means the injury is where? It has happened somewhere here in the horizontal part, right? So that's how topography is going to help us. Then how will Bell's palsy or how will facial nerve injury present? So first of all, we learn UMN versus LMN. So this is a figure showing UMN lesion. This is a figure showing LMN lesion. What do I mean by UMN? Upper motor neuron, just like we say corticospinal, right? In neuro, we have learned this. This is where you have your corticobulbar fibers, also called as supranuclear fibers. So all the fibers coming from cortex till the facial nucleus is UMN. Everything from facial nucleus itself, including the nerve, is all LMN. So all of these things are going to have LMN palsy, where all the muscles of my face will go, right? So this is where in LMN lesions, ipsilateral full half of the face will go on the same side as the nerve injured, whereas UMN lesion will present on the contralateral side. So this will be contralateral, and very important, the upper face is spared, particularly the forehead is spared. Why? Because it gets bilateral involvement. So if one side is going, the other side will supply. So that is why this is what is spared. Another thing that is spared in UMN are emotional movements. For example, everything which is regulated by the limbic system, those tracks are not involved. Only the corticobulbar, whatever motor cortex is sending, is involved. So two buzzwords for UMN lesion: forehead spared and emotional movement spared. All right. So any emotion related crying, etc., will be spared. But in element, everything on that same side will go. And how does the patient look? Something like this. So you can see forehead ke wrinkles lost ho gaye hain. I can't close my eyes because orbicularis oculi is not working. So wide palpebral fissure. You will have lag of thalamus because you can't close the eyes, resulting in keratitis also. You will continuously have tears dropping because the palpebral fissure, the eye is getting irritated. Absence of nasolabial fold and drooping of angle of mouth. So all of these things are what are gonna happen in Bell's palsy. Right, so let's do two syndromes. So if I have such a presentation, Bell's palsy along with two things, okay? So first is Ramsay-Hunt syndrome. What is that? Ramsay-Hunt syndrome is nothing but herpes zoster oticus. Yeah, so this is where you're gonna have Bell's palsy along with vesicles in the ear. So there are going to be vesicles in the ear. All right, so that's Ramsay Hunt, and it is because of varicella zoster, herpes zoster oticus. It's reactivation of the varicella zoster. It is lying dormant in the geniculate ganglion. So varicella zoster virus in geniculate ganglion reactivation will result in this. And if I have Bell's palsy with a figure which is shown here, that is fissured tongue, this is what is called as Mulkerson-Rosenthal syndrome. Another one is crocodile tears. What is crocodile tears? Gustatory lacrimation. This is very similar to what we learned in Frey syndrome. Remember, gustatory sweating. Anytime one is salivating, they are having mixing of sympathetic parasympathetic fibers. Now, what are crocodile tears? So this is basically mixed and impaired nerve regeneration which has happened where you have had mixing of your lacrimation GSPN fibers with your gustatory fibers, that's called a tympani. They've gotten mixed. So both of these things are happening together. This is where, remember, two bows. This is also called as Bogorad syndrome. And one of the things which are shown results here is Botox, botulinum toxin injection, right? So that's crocodile tears. What are the surgical landmarks? So, facial nerve runs in the parotid. That is called as Petty's plane. I have taught you this in anatomy, where the facial nerve, the retromandibular vein and ECA run in the parotid substance, dividing into superficial and deep lobe. So that is where it can get injured. So what are the landmarks? Very important. One is the tragus, right? Then you have tympanomastoid suture, styloid process, and posterior belly of digastric. Don't mix it with anterior. You can do it by nerve supply also. Anterior belly is V3, posterior belly is 7th nerve, right? So we can solve it through this. And if it is injured during surgery, intraoperatively, and it is detected that it's injured, we will repair it. And what we do is we put a great auricular nerve cable graft, right? So the nerve which is used to replace the cut part is great auricular nerve. So that's called as cable grafting. All right. So this is about facial nerve injury and its course. Moving on to some paranasal sinus x-rays. So now we'll be focusing on paranasal sinus and nose. So let's look at these x-rays, very commonly asked. The first one, what do you see here? So whenever you are able to see the maxillary sinus, right? This is what is a Waters view. But I can see the mouth is open. So if mouth is open, you will say that, ma'am, this is modified Waters view, also called as Pierce view. So first of all, understand how it's taken. If my face is straight right now, my maxillary sinuses are getting overlapped by the mastoid sinus. They are in the same line and will overlap. So what I need to do is lift my chin up. So when I lift my chin up, the maxillary sinus is upper and mastoid sinus is niche. So now look at this. I have the maxillary sinuses and you can see the mastoid and niche. They are not overlapping because when I keep my face straight, it would look something like this. Can you see? Maxillary sinuses are obscured by all of these mastoid air cells. So this is why this x-ray is taken, with your chin up, and that is something they asked, a very extreme question, that what is the angle of the face. So imagine this is the x-ray detector and imagine hard that this is a person. This is the angle between the chin and the plate, and that was asked as 37 degrees. So this is how the ray passes from occiput to the chin. So this is called as occipito-mental view. Mental means chin here, okay, not mental. So this is occipito-mental view. and this angle is 37 degrees. It is the best for maxillary sinus because I'm doing this particularly for maxillary sinus. So now understand, how will a normal maxillary sinus look? It should be filled with air. Always compare it with the orbit. So if you see that it's wider than the orbit, means it's involved. And now can you see how there are these air fluid levels? So this is where in this patient I will report it as bilateral maxillary sinusitis. So this is how sinusitis appears. But if you see upper, convex up, that means it's a mass. So this is how a polyp, a maxillary sinus polyp would appear. Alright, so this is the difference between a sinusitis and a polyp. Another point, why did I keep the mouth open? Why did we have to do a modified Waters view? The reason for that is if we keep the mouth open through, this part, I can also see the sphenoid sinus and I can also see the frontal sinus. So here I can see all the sinuses. I can even see anterior ethmoidal except posterior ethmoid. So the only sinus I don't see on Waters view is posterior ethmoidal sinus. Okay? Then if the face is straight, do you agree if I want to see frontal sinus, I don't need to do all this. I can just keep the face straight. So that is what is this view where I'm focusing on the frontal sinuses, not really on the maxillary sinus. So this is what is called as Caldwell's view, and it's particularly meant for frontal sinuses, right? And it is where the face is straight, no real angulation. So this is what is called as an occipitofrontal view. The rays will pass from occiput to frontal, all right, frontal sinus. This has been asked previously, where now the rays are not from piche to aage, occiput to frontal, but from frontal to occiput with an angle of 30 degree. This is what is called as Townes view. All right. So Townes view, what all can you see here? Can you see this is the foramen magnum, right? And at the base, you can also see here through it is the sella. So I can see sella turcica, foramen magnum, but what I'm really doing it to see is our petrous apex. So this is where I can see the petrous temporal bone. I can see the mastoid air cells, right? So that's essentially why we are doing the Townes view. You should know how to recognize it. Then we talk about the anatomy aspect. So before we talk about all of the x-rays, right, one thing is to be clear is x-rays are done as an initial investigation. For any paranasal sinus pathology, it would always be confirmed by the investigation of choice, which is high resolution CT. Who's the gold standard though? That's FES, functional endoscopic sinus surgery, right? Where you go in with an endoscope and you see and you treat itself in the same setting, right? So that's the gold standard. Let's have a look at the CT anatomy now. So here, what are you seeing as the inferior turbinate, right? So let's keep labeling. This is inferior turbinate. Can you appreciate the maxillary sinus, right? The bone is white, so it's CT, air is black, right? So that's why we do HRCT. No need to give contrast if, we are not suspecting a tumor. So this is inferior turbinate, and from the inferior turbinate, do you see a bone coming out? What is that bone? So that has to be the uncinate process. So this is the uncinate process. And what do you see here from the medial wall? So this is the orbit, right? So on the medial wall, what I see is bulla ethmoidalis. So I can see the bulla ethmoidalis and I can see the uncinate process here. So this becomes the maxillary sinus ostium. So what we are learning now is actually osteomeatal unit. What is forming this ostium, maxillary sinus ostium? So that's called as osteomeatal unit. So this is the part of ostium. I have to go through this two-dimensional area which is called as infundibulum. So this is the part that we call as infundibulum, and it opens into this 3D space. When I come out, that is called as hiatus semilunaris. All right. So what all parts did I name? Bulla ethmoidalis from the medial wall, largest ethmoidal air cell. Now ये bulla, biggest. I had uncinate process coming in. I had infundibulum opening into hiatus semilunaris. So this is what forms this osteomeatal unit. What you see here is the middle turbinate. Now, inferior turbinate is an independent bone. Can you see here? But the middle and the superior turbinate both will come from the ethmoidal roof. So that's what I can appreciate. Middle turbinate, superior turbinate. Middle turbinate in this case is pneumatized. Yeah, so that's an anatomical variant which we call as concha bullosa. So this is concha bullosa, which is a pneumatized middle turbinate. It's an anatomical variant. All right, so that's what I can appreciate here. So this is what we are learning from this anatomy here, right? So let's do some more questions theoretical and then we'll correlate it with CT. So drainage, what drains in the inferior meatus is just one thing, that is nasolacrimal duct. You need to know the direction of nasolacrimal duct. So it is lateral, downwards and backwards, right? So two letters to naam mein hai, lateral and downward, and it's also going posterior. Middle meatus, remember a mnemonic frame, everything is there in frame. So what is frame? Frontal sinus drains here, you have anterior ethmoidal drains here, and most importantly maxillary sinus opens in the middle meatus. And very important, if you do a DCR, right, so if you do a dacrocystorhinostomia opening, if NLD is obstructed, you'll not open it in inferior, you'll open it in middle. So you can remember frame DCR. Yeah, that's important. Another correlation, which may be asked is, what is a foramen in relation to middle meatus? So that happens to be the sphenopalatine foramina. So we localize the middle meatus and reach the sphenopalatine foramen. This I will teach you is where the JNA arises from. So this is the origin of JNA. And if we want to, do a maxillary nerve block, this is the foramina to target. So just a landmark for this potential question. Superior meatus is posterior ethmoid, okay? So anterior ethmoid ho gaya, posterior ethmoid, superior meatus, and sphenoethmoidal recess is sphenoid sinus opening, right? Now let's talk about some ethmoidal air cells. Anterior most, आगे, in Gujarati we call agar. So that's literally what this is called, agar nasai cell. सबसे आगे, anterior is agar nasai. The largest one we already saw was medial to the orbit, that is bulla ethmoidalis. ठीक है, so सबसे आगे, not in this plane. Even if I cut anterior to this plane, I'll see agar nasai. बुल्ला ethmoidalis I've seen. Instead of being medial, एक infraorbital cell होता है, and you can see how that can occlude the ostium, right? So that problematic cell is Haller cell. So Haller cell का problem क्या? It's a variant. If it is present, it can be associated with ostium getting blocked. And posterior most ethmoid cell, optic nerve compression it can do. ON, it's in the name, Onodi cell, right? So Onodi cell is posterior most ethmoidal cell. Then anterior cells which can go into the frontal sinus are called as frontoethmoidal cells, right? So why would they ask that? That's in the name. So frontoethmoidal cell, but they are also called as Kun cells. So that's what they can pick up and ask. So Kun cells are the ones which are ethmoid, but they can extend into frontal sinus. So let's try and understand these if they ask you an image from this. So first of all, do you appreciate this is a sagittal view? This is aage, this is piche. So let's start from easiest thing. Can you see the sphenoid sinus, and can you see how cella is just above the sphenoid? So that's why we adopt a transnasal, transphenoidal route for accessing pituitary. Yeah, so that makes sense. Then can you appreciate this is what is the middle turbinate, and there is one lamella coming from the middle turbinate which divides ethmoid into anterior, posterior. So even if you are not seeing, that's fine. But what is a theoretical point is there is something called as basal lamella that divides ethmoid into anterior, posterior cells, right? On what basis are we saying anterior, posterior? Basal lamella, it's a part of the middle turbinate. Okay. Then look here. So this is what is your frontal sinus, and this is the frontal sinus opening in the middle meatus. Can you see in front of the opening? आगे, सबसे आगे का cell कौन होगा? Agar nasai. So this is what is your agar nasai cell. Okay. Are we anterior or posterior? Now I'm taking a coronal and I'm cutting through here. So this is where I can see the two sphenoid sinuses. Yeah, so this is a posterior horn. So what must be these cells? If I tell you this is optic nerve, you will know that, ma'am, this must be onodi. So now do you see, if this cell expands, it will compress this optic nerve. All right, so this is onodi cell. And then look at this. So this is the plane of the orbit. So can you see नीचे से cell आ रहा है? So who are these नीचे वाले cells? They are Haller cells, and you can see how they will block the sinus ostium. Okay, so सबसे बड़ा medial bulla ethmoidalis. इधर से आएगा कुछ Haller. आगे का प्लेन agonizai, पीछे का प्लेन onodi. So if you can see a plane where I'm seeing uncinate, I'm seeing inferior middle turbinate, don't answer agonizai or onodi, right? They are not going to be in this plane. We are cutting somewhere in the middle. So you can always look at the orbit and know कि हम आगे cut कर रहे हैं, पीछे cut कर रहे हैं. So this is where, this is the orbit. So I am cutting anteriorly, but it's not anterior enough to be agonizai, right? So remember this plane. This is the plane of bulla ethmoidalis, right? So that's about it. Talking just briefly about endoscopy, I mean, it's a very expert dependent thing, but you know, they might ask you some basic questions. So this is what a nasal endoscope looks like. It's color coded, right? So you can see some yellow color here, so it has a color coding. I don't think you need to know that. So this is nasal endoscope. What you see here of the endoscopy view, this has been asked. So this is the septum medially. So what must be this projection right here? So this is nothing but the inferior turbinate, which will give rise to the uncinate process. So they have asked this in the past, that what is the first step in FIS? It is uncinectomy. Do you get that? Because this is where I want to reach, right? मुझे maxillary sinus ostium जाना है, and I have come from somewhere here, right? I have come and I have to navigate my way here. So do you agree this will block my passage? So they will cut out the uncinate and they will enter the maxillary sinus and remove the pathology, right? So this is inferior turbinate and they will go through, you know, through this. What is this structure? So first of all, do you see like a very smooth thing? This could be two things, all right? One, this could be a hypertrophied turbinate, yeah, or it could be a concha bullosa, right? Pneumatized middle turbinate. So you can see how smooth this is, right? So if it is a smooth structure, it's concha. So this right here is what is showing you an endoscopy view of concha bullosa, which may sometimes, you know, occlude your view because it's too large. Hypertrophied turbinate will have this irregular sort of an appearance. Okay, so this is about few of the images. This is quite extra, not been asked, just a prediction. So this is where you have various passes, the curves, the turns that an endoscopic surgeon will take. First is inferior meatus pe to reach the nasolacrimal duct. Second route they can take, figure these as routes. Second route or rasta is middle meatus ka lateral wall, where they'll enter the maxillary sinus ostium. That makes sense. Middle meatus ka lateral maxillary sinus. But if I go from medial surface of middle turbinate, now I will enter behind, is plane se piche. I'll enter the sphenoethmoidal recess, right? So it's basically just three routes. So they might just ask you that. All right. So this is about paranasal sinus anatomy. Now we talk about the sinus pathologies. So first thing, sinusitis and its complications. So few words. Most common site of sinusitis in children is going to be the ethmoid sinusitis, whereas in adult it is maxillary sinuses, right? So that's maxillary sinusitis. Which sinusitis is mucocele and osteomyelitis a complication of? That's frontal, right? Frontal sinusitis can have a mucocele. Mucocele is going to be, you know, if the ostium is blocked, what will happen? All the secretions will keep collecting, will form benign smooth mass. So always remember, it's a benign collection of secretions, right? It's not a tumor. So it will present as a mass, but it's not going to have any inflammatory signs. It's not going to enhance, right? It's going to be just a collection. So one thing would be, it's very T2 hyper intense because it's just secretions, right? So fluid dikhega MRI pe. So it's a very easy radiological diagnosis. Osteomyelitis, on the other hand, clinically might mimic a tumor. In fact, this person's name is Pot Uncle. Okay, so Pot Uncle went to ENT surgeon. That surgeon, I think I have a tumor. And the ENT surgeon said, yes, you have, and we'll call it puffy tumor. Imagine. So, this is Pott's puffy tumor, which is actually a misnomer. It is not a tumor. When we did the MR, we came to know, oh, Pott uncle does not have a tumor. Can you see how there is just peripheral enhancement here? So, I can see this peripheral enhancement, which is subperiosteal. Can you see? This is an MRI. So, the bone is black. This is the brain. So, it's outside the brain, just attached to the bone. So this is nothing but subperiosteal abscess. You know, anything which enhances periphery is an abscess. So this is a subperiosteal abscess which this uncle has secondary to frontal sinusitis. All right, so it's a misnomer, it's not a tumor. Most common orbital complication obviously is going to happen from ethmoid, right? Because ethmoid sinus is closest to the orbit. So that is where there is a thin wall separating them. What do you call this thin wall separating the ethmoid sinus from the orbit? That is called as lamina papyracea. Yeah, the name itself tells you that it's paper thin wall. So that's why any ethmoid sinus can easily, you know, enter into the orbit. Fine, so quite logical. First sinus to be present radiologically is our largest one, that's maxillary, and not present at birth, remember, is frontal. Okay, so frontal sinus not present at birth, it develops later. Okay, so these are some questions looking at another condition. So what is this? Again an MRI, and what this is I have given contrast, and I'm seeing that this particular turbinate on the right side, you can see inferior turbinate is enhancing, left side everything is enhancing, but this turbinate is not enhancing, and they named it black turbinate sign. So this is what was called as black turbinate sign, and what that indicates is ischemic necrosis. There must be an infection which is angioinvasive. So this is where on clinical examination we saw this black necrotic lesion, and you know we call this black fungus. You remember COVID pandemic, black fungus? This is nothing but mucormycosis. So black fungus also is a misnomer. It's not a true black fungus. You know, in derma we have studied Tinea nigra. That's black fungus. So this is something which was called black fungus. Why? Because it led to ischemic necrosis, because mucor is an angioinvasive fungus. It enters the blood vessels, right? So that is what is mucormycosis. So this is about mucormycosis. Now we go to aspergillus. You know, aspergillus fumigatus, fumes go to the nose. So it's aspergillus fumigatus, which is mainly going to cause paranasal sinus infections. Now there are two things. One is where before the fungus can infect us, we are going to have an allergic component to it. So this is nothing but allergic fungal sinusitis. How do I know that? So look at this. First of all, right, left we are clear with. This is right, this is left, as how we learn in radiology. So what I can see is entire left nasal cavity and maxillary sinus. Left rhinosinusitis hai. And I can see what is called as double density. There are some white fungal elements, and then I can see dark edema. All right, so this is what is called as very typical double density sign, which tells me that there is a hyperdense element of fungal hyphae and mucin. So usse pata chalta hai that it's allergy, double density sign. Clinically, there's a very bad term that they give, which is called as peanut butter discharge, right? So peanut butter, whoever is a fan of peanut butter may not like this. They say that whatever comes out of their nose is thick brown like peanut butter. All right, so that's allergic fungal sinusitis, and the criteria has been asked once, that is called as Bent and Kunz criteria. So do anyone major or minor? So they had asked all are major except, yeah. So one, it's a type 1 hypersensitivity associated with polyps. The polyps associated with allergy tend to be ethmoidal polyps, right? So ethmoidal polyps. CT appearance is characteristic, eosinophilic mucin है, and positive fungal stain. What is to be noted is culture is minor. Yeah, so that is what they gave in the options. So remember, it's allergic, it's not invasive, right? So doing a culture positive is not mandatory. Allergy है वो mandatory है. Other minor points like asthma, unilateral erosion, Charcot lead, and eosinophilia, right? So just see the major ones. Type 1, nasal polyp. Even if you don't want to, see the red ones. Fungal stain is major, culture is minor. On the other hand, if you have a patient who's immunocompromised or let's say diabetic patient, right, that is the history you will get in both of these, mucor and invasive aspergillosis. So this is invasive aspergillosis, where can you see how there is sinus which is opacified, and along with that, see how it has destroyed bones, it has destroyed the turbinates, it's destroyed the lamina papyracea and gone into orbit. So the hallmark of fungal sinusitis is bone erosion. There is going to be erosions of the bones that happen. All right, so this is about aspergillus, one allergic one which is benign, where the treatment is mainly steroids, right? So allergic fungal sinusitis, the treatment can just be steroids, whereas in allergic the treatment has to be antifungals, right? So for invasive aspergillus, the antifungal of choice is voriconazole. All right, so this is what I need to remember here. The next one, the next pathology is examiner's favorite. You know, every exam they ask a question on JNA. The history is very obvious. Adolescent male with epistaxis. You have to only think of JNA, juvenile nasal angiofibroma. So what does the name say? Juvenile, adolescent age. Nasal or nasopharynx का मास है. Angiofibroma. That's an important word, because that tells me there's only blood vessel and fibrous tissue. There is no muscle to stop the bleeding, right? So that is why, you know, these vessels proliferate and they keep bleeding. And this happens to be androgen dependent, and that is why we see it only in males, or more commonly in males, because it's androgen dependent. So what is the takeaway is, never ever stick a needle into this, because the bleeding will never stop. It's so vascular. So very important, biopsy FNAC is contraindicated. Patient will bleed to death. Investigation of choice, that's why it has to be radiology, where I do a CECT to see the enhancement, right? So look at the CT here. Where is the mass? First of all, can you see we are cutting an axial section at the level of maxillary sinus. So ये right side है, ये left side है. Can you see there is one white thing here which is growing like a dumbbell? Yeah. So it begins somewhere here. So the origin, I told you, where does it originate from? It's the sphenopalatine foramen. So it originates from the sphenopalatine foramen and it grows laterally. Yeah, so how it grows. Now understand this anatomy. I'm going to throw some big words at you, but don't get overwhelmed. Three letters se shuru karte hain. So it starts from sphenopalatine foramen. It grows then laterally. Yeah, so it has to grow laterally into this infratemporal fossa. And what it crosses in between is the pterygopalatine fossa. So sphenopalatine foramen, this is pterygoid plate. So pterygopalatine fossa, and laterally behind the maxillary sinus is the infratemporal fossa. So it's pushing. Can you appreciate now on the right side? The maxillary sinus, aisa lag raha hai when you look at it, it's being pushed. So this sign is what is called as Hohmann-Miller sign. So Hohmann, you can remember, man mein hota hai ye. So Hohmann-Miller sign is where the posterior wall of maxillary sinus is pushed by the mass. So don't have to memorize it, just you've seen it now, you've understood it. And clinically it also results in this fullness of you know, the cheek and the nose, you can appreciate. So this is what is called as the frog sign. The face looks like a frog. Okay, so this is how it grows, and this staging is called as Radkowski staging. It won't be difficult to remember. You will be able to remember this because now you've learned it, right? So see, 1A starting in the nose, 1B paranasal sinus. Okay, so these are local. Now what were the 3-letter words I taught you? First, SPF. Yeah. Second, pterygopalatine fossa. pushing the maxilla forward. Can I say this is nothing but my Hohmann-Miller sign only, right? So Hohmann-Miller sign matlab to be. And then it's going into infratemporal fossa. So here are our three words, right? So sphenopalatine, pterygopalatine, infratemporal fossa. So this is how it grows laterally. Once it goes to skull base, it's 3A, extensive intracranial, that's bad, that's 3B. Okay, so this is what we need to remember from GNA. Talking about the management, right? So the treatment, it's a very vascular tumor. So what is very important is we have to do a pre-operative embolization if it's a surgical candidate. So surgery is the mainstay of treatment, right? We would prefer an endoscopic endonasal view if possible, right? So if operative, endoscopically they'll operate, otherwise they'll have to open up. So if this is not possible, then they will do an open surgery. Before the surgery, they will ask for DSA, right? That please embolize the feeding vessels, and the feeding vessels come from the maxillary artery. So what we do is we puncture femoral artery, reach the ECA, go to maxillary, and we see what is supplying the tumor, and we embolize the branches. So that decreases the bleeding by many folds, right? So that's very important. If it is inoperable, intracranial extension ho gaya hai, inoperable hai, in that case we can give radiotherapy, and we can also try flutamide, which is nothing but anti-androgen because it's androgen dependent tumor. Okay, now let's talk about polyps, right? So what is this polyp? So you can see how this is arising from the maxillary antrum and going into the nose. So what is usually a single large polyp is an antrochoanal polyp, right? So antrochoanal versus ethmoidal polyps. So antrochoanal will be usually large unilateral associated with infection, whereas ethmoidal will be bilateral, usually associated with allergies, right? One of the associations of ethmoidal polyps is Samter's triad. Remember, vowels stick together. So Samter's triad is history of atopy or asthma with ethmoidal polyps and hypersensitivity to NSAIDs, right? So they are hypersensitive to NSAIDs, particularly aspirin. So you can remember A and E vowels stick together. Non-allergic, non-IG mediated. So this is very important that this is not IG mediated. Fine. So this is what is linked with atopy, but non-allergic, non-IG mediated component. This has been asked. Okay, so how do we treat? So in antrochoanal polyp, because it's one polyp, it's easier to avulse them. The treatment is usually surgical, and ethmoidal, the treatment is usually medical management. Do remember that polyps don't bleed to touch. They are mucosal swellings, right? So polyps don't bleed to touch, all right? No bleed. So that's important. Then we look at this particular image where what you can see something coming out in the pharynx. So here there are two possibilities, right? So this is what is called as Dodd sign, where if I can see that there is a crescent, can you see one crescent of air around this mass? That tells me that it's not arising from nasopharynx, it's covered by air. So that is what tells me it's a polyp which has prolapsed into the pharynx, antrochoanal polyp here, where I see a crescent of air. But if I didn't see that crescent, it could have been JNA. So this is JNA versus polyp. Okay, so Dodd sign can be asked. What is this maneuver that I'm showing? So this is where, what would be the history if I ask you? So the history would be there's a newborn baby who becomes cyanosed every time they are feeding. So anytime you get such an history, na, two DDs run through your mind. One is tracheoesophageal fistula. In that, they'll give you every time the baby feeds, there is drooling, right? Because esophageal atresia hai, whatever milk baby will drink will come out. So that's drooling. But if they give you cyanosis while feeding, right, that tells you that there is choanal atresia. That tells you that the baby was dependent on the mouth for breathing as well, because nose is blocked. So that is choanal atresia, and the moment the baby starts feeding, mouth is occupied, so baby turns blue. Okay, so how do you diagnose this? It's a clinical diagnosis. You can just pass a catheter down the nares and it will not pass. So what do you do? So an emergent treatment is what is being shown here, called as McGovern's maneuver, where we give this nipple sort of a thing which enables this baby to breathe and feed at the same time, and then you have to operate this child. Okay, so this is what is choanal atresia. Talking further about some more abnormalities. So first we talk about very important NPCA, nasopharyngeal carcinoma, happens in elderly. It's linked with EBV, very important. In addition, it is also linked with, Chinese food, which has high nitrosamine. So not just Chinese food, basically any, salted fish in the diet happens more, in the Asian part, right? China and Japan. So salted fish consumption has also been linked with NPCA. It is quite radio sensitive, so radiotherapy can be used in the treatment. And turns out the most common clinical feature here is lymph nodes. So it presents as cervical lymph nodes as the first site of, presentation. So because the mass is quite deep rooted, so where it arises is called as fossa of Rosenmuller. Don't mix this with sphenopalatine foramen, which is for JNM. So this arises from fossa of Rosenmuller, and this is where, we are looking at the nasopharynx now through an endoscope. So यहाँ पे दिख रहा है, this is the eustachian tube, and around the eustachian tube what we have is torus tubaris. All right, so torus tubaris is nothing but the muscle which opens and closes the eustachian tube. So this fossa of Rosenmuller will give rise to mass which will occlude the eustachian tube, and it can involve multiple cranial nerves which are there in the nasopharynx. So that gives us the Trotter's triad, which can be remembered as NPCA. So N for neuralgia. Which neuralgia? Trigeminal neuralgia. P for palatal palsy, right? Because of 10th cranial nerve. And C for conductive hearing loss. Why does that happen? That is nothing but serous otitis media. So because the eustachian tube gets blocked, we had learned this, we will have glue ear or serous otitis media. So we can put a grommet, but we'll have to treat the primary lesion. So remember, NPC. This is nasopharyngeal carcinoma. A nasopharyngeal mass in children. What did we learn? The moment you hear serous otitis media, अगर child है, think adenoids. अगर elderly है, think NPCA. So now let's think adenoids. So this is where an X-ray is showing this mass in the nasopharynx. Can you appreciate this? So this is nothing but adenoids, right? So this is what we are seeing in the nasopharynx. Can you appreciate this? X-ray can be given to you. This is adenoids. All right, so adenoids will also cause hearing loss in children. So what are the indications of removing them? If adenoids are severe enough to cause sleep apnea, they are causing recurrent serous otitis media, recurrent infection. So this many times they have given a child who has, hearing loss and is doing mouth breathing. What will you do? So the answer usually is put a grommet plus adenoidectomy, right? You'll have to do both, treat the serous otitis media and treat the root cause. Recurrent infections also. Contraindications, very important, would be bleeding, right? Of course, acute infection, you will let the acute infection be healed, and velopharyngeal insufficiency, which can, basically be aggravated. Velopharyngeal insufficiency means there's a problem with the palatal muscles, and in that case, you don't want to operate. Fine. So this is where the adenoids are what do not have any capsule or crypts, unlike our tonsils, right, which have a capsule and a crypt, multiple crypts. So adenoids don't. So this is what you are seeing as your Voldier's ring. So what forms the Voldier's ring? So what Voldier's ring is formed by is the lingual tonsils, base of tongue, palatine tonsils. You can see the crypts here. The tubal tonsil, what we saw, right? This is where you will have the tubal tonsil, tubal lymph nodes, and the nasal tonsils, which are the adenoids. Here you can remember GT in LA. You know how in biochemistry we learned high court in LA? Now there is a GT, grand test in LA. Okay, so what is GT in LA? So Lushka's nodes are what are called as adenoids, and Gerlach's nodes are what are palatine tonsils. So just remember GT in LA. L is adenoids, T tonsils are Gerlach's. Fine. So this is about Voldier's ring. Now, what will happen in any child who has adenoidal hypertrophy? This is what is called as rhinolalia clausa, where essentially the nose is occluded. Okay, so the commonest causes is adenoids, where the nose is blocked, and this is what we call as typical adenoid facies, where you will see, right, that they are obligate mouth breathers. नाक से breathe नहीं ले पाते, so mouth breathing करेंगे, because of which they have teeth which are crowded, right? So you will see crowding of the teeth, right? So that is the kind of presentation in adenoid facies, or any like nasopharyngeal mass will lead to rhinolalia clausa, closed. Whereas rhinolalia aperta is hypernasality. You are having more nasality. So this is aperta, which is associated with velopharyngeal insufficiency. What we learned above, right, where the palatal muscles don't work. So what I mean here is there's something called as passivance ridge, right? What is passivance ridge? Is a combination of palatopharyngeus and superior constrictor. So these muscles contract every time you eat something, you swallow something. So what happens? That allows the food to go down into the laryngopharynx without refluxing into nasopharynx. So it blocks the oropharynx, right? So this is what does not work here. So that's why whatever I'm speaking is, going more in the nose. So that is hypernasality. Okay, so this is what is associated either with, cleft palate or palatal palsy because of 10th cranial nerve. Fine. So this is velopharyngeal insufficiency. So this is about adenoids, indications, contraindications. Now we talk about another mass which happens in older patients, right? So this is something where, can you see how it looks like a brain? So this is called as cerebriform appearance. Both on gross and MRI, you can see left side maxillary sinus, there's a mass which has convolutions like the brain. So this is what is called as inverted papilloma. All right, so inverted papilloma is what is also called as Ringer's tumor. So happens in elderly, fine, and it arises from what is called as Schneiderian membrane, the mucosal membrane of the paranasal sinus. All right, very important, it is linked with HPV. So NPC was linked with EBV, this is linked with HPV. It has a higher chance of recurrence when removed and can also turn into squamous cell carcinoma. So it's a bad lesion to have. Okay, it looks like the brain, Schneiderian membrane, Ringer's tumor, HPV become the most important part here, and high chance of recurrence, so it needs to be removed. Fine. So on that note, we will learn some incisions. All right. So this is what is Moore's incision that we can give for removing an inverted papilloma. This is what is called as lateral rhinotomy. So we are giving an incision along the lateral nose. It can also be called as medial maxillectomy. So that's Moore's incision. Whereas if I'm opening the complete, more exposure, right, opening the complete maxillary fossa, that is Weber-Ferguson, which is usually done for CA of the maxillary sinus. While we are talking about incisions, look at this. This is Gluck Sorensen, which is for total laryngectomy. Okay, this was asked in NEET 2 years back. This is nothing but an open rhinoplasty incision, right? So this is open rhinoplasty incision was asked. And then this is something which has not been asked so far, and I think this can be asked, is Caldwell look approach. So this is where it's an approach to enter the maxillary sinus via the teeth. Okay, so just from below the maxillary sinus I can enter. So this is where I give an incision above the molars and I reach into the maxillary sinus, hence called antrostomy. Okay, so this is the area that they are highlighting. So this is your Caldwell look approach. Now we talk a little about maxillary sinus cancer, right? So there are these two prognostic systems. Ultimately the concept is anything which is above, near the orbit is bad. Okay, so that's the point. For that, they have suggested two things. This is what is Ongren's line. This is the more widely used method where you are drawing a oblique line here from the medial part of the orbit and going downwards. So everything which is above, if the maxillary sinus goes above, it's bad. That's all. It's the takeaway. Above the Ongren's line is bad. Similarly, there's this Lederman system. Okay, so this is the Lederman classification. They're similar. Whatever is along the maxillary sinus is what is the medium, mesostructure. This is suprastructure. This is infrastructure. So what would be bad? Suprastructure is bad. Infrastructure is the best. So it keeps worsening as we go above, right? So these are the two prognostic systems for maxillary cancer, right? And two risk factors would add adeno-CA. So this is for adeno-CA, whereas nickel is for squamous cell carcinoma of the paranasal sinuses, right? Then a few instruments here. I hope both of these, you remember from your undergrad. These are nasal speculums for nasal examination, anterior nasal examination. So both of these are anterior nasal speculums. This one is what is your thudiculum, right? So I'm sure you all remember this. And this is your Killian's anterior nasal speculum. So it's for widening the anterior aspect of the nose. Whereas posteriorly, which out of this is posterior rhinoscopy? So this curved one, right? So curved one is posterior rhinoscopy mirror, whereas this is indirect laryngoscope. How I remember this is L. L is a letter which is straight, na? So this is what looks like an L. Whereas rhinoscopy, R is so curved. So this is curved. So that's how you can remember. Fine. So this is about some instruments. Now we talk about trauma. So the next 2 pages we'll talk about facial trauma, quite important. First, what we learn is the Lefort classification system, right? So Lefort classification is basically complex facial fractures which involve the facial buttresses. What they mean are what hold together our facial bones, right? One of the crucial elements of Lefort is pterygoid. So this is where the hallmark is. In all of them, the pterygoid plates are fractured, and hence the central aspect of face is gone, right? Now you see which plane is it affecting. So if I see it is below the maxillary sinus, this is Lefort 1. Here you can remember that the palate is floating, right? So this is also called as floating palate. This is where you will have what is called as Guerin sign. This is Guerin sign where I have a great palatine artery hematoma. So it bleeds GPA hematoma. Guerin is Lefort 1. So Lefort 2 is where it's going, from the maxillary sinus, and it's mainly infraorbital, if you want to remember one word. So this is what is called as floating maxilla, right? So this is where the maxilla, entire maxilla is now on its own, whereas the last one is the most severe one where there's a complete craniofacial disjunction. So this is called as floating face, right? The entire face is disjointed. So that's one way to remember it. Otherwise, maxillary sinus, infraorbite, complete. All right. So which out of these 3 can have CSF rhinorrhea? Just looking at it, whatever involves the skull base. So these 2 are what are associated with CSF rhinorrhea. Quite basic. So this is about Lefort fractures, complex facial fractures. Then coming to most commonly asked in the exam, can you see on the left side the floor of orbit has fractured? So this is floor of orbit fracture, which has been given multiple names, and each name is adding some value. First, it is called as teardrop fracture. That tells you that it does look like a teardrop because floor of orbit fracture. Second, it is also called as trap door fracture. That tells you that something must be getting trapped. So that happens to be the inferior rectus. So this is where the inferior rectus muscle can get entrapped. Yeah. So that's trapdoor fracture. And then another name is called as blowout fracture, and that suggests the mechanism. Somebody giving a blow into the orbit, the intraorbital pressure increases and the floor gives way, right? So just if you know the 3 names, you'll be able to figure it out. So this is floor of orbit fracture. Then we talk about temporal bone fracture. So look at this. Can you appreciate this is our entire temporal bone and this is the petrous apex. Here it is going along the petrous bone. So when it is going along, it is longitudinal fracture. When it is perpendicular to it, it's transverse. So all you remember and imagine is when it's going along, it's longitudinal. And see this. This is where you have your middle ear and this is where you have inner ear. So along will cut through the middle ear. Whereas if I cut perpendicular, now the inner ear can be injured. And that's all you need because they'll ask you true or false here. So long is parallel going through middle ear. So there'll be conductive hearing loss, ossicular injury, tympanic membrane rupture, not inner ear. Whereas nerve, facial nerve, SNHL, inner ear will all be transverse. Yeah, so fairly simple. Then we look at this. This is something which I can expect because there are three things which form the tripod. So they can ask you an all except question. So what is our tripod fracture? So this is our zygomatic bone, right? So three things: zygomatico frontal. Yeah, so I'm gonna write ZF. Zygomatico temporal. So zygomatico temporal and zygomatico maxillary. So these are the three things. So just remember FTM. You can remember Fatima. Okay, so Fatima had a tripod fracture. So frontal, temporal, maxilla, three things which are going. Okay, then we talk about skull base injury. So first I need to teach you the skull base anatomy. All right, so I'll make a drawing or I try at least and then we can look at the CT. Okay, so what is this is crista galli. On the two sides of crista galli, we have the cribriform plate. The cribriform plate will grow laterally, hence called lateral lamella, and will go up to become the roof of ethmoid, that is fovea ethmoidalis, right? So this is what is forming the skull base. What we do is we measure the depth here from fovea ethmoidalis to the cribriform plate, and that is called as Kiros classification. Expected question, never been asked. Okay, you'll give me a big party if this comes. So Kiros classification tells us how deep the cribriform plate is, and the deeper it is, the more chance of skull base injury will happen during FIS, right? So this is where skull base injury will lead to CSF rhinorrhea. CSF will communicate with the nose. So more chance of skull base injury will happen during FIS, right? So that is why we use before any FIS, we do a paranasal sinus CT and we give them the depth, all right, of Kiros classification. So just have this brief idea. So now look at this CT. Can you appreciate? This is the crista galli. This is where you can see this person's cribriform plate is fractured. This is where I would have had lateral lamella, and this is my fovea ethmoidalis, as the name suggests, fovea, roof of ethmoid, right? So this is where you can see a cribriform plate fracture. Yeah, so this is CSF rhinorrhea. So let's say somebody is constantly having nasal discharge. How do you know it's not how do you know it's not just rhinitis? Okay, so 2-3 points. One, if you take it on a handkerchief, you'll see this halo or this target sign where you have blood mixed with CSF, which is forming different layers. So that's one. The second thing is, will CSF stiffen the handkerchief? No, that's mucus, right? So this will not stiffen the handkerchief. So that is one thing which is called as handkerchief sign. Second, can this be sniffed back? Of course not. CSF can't be sniffed back. I'm not even going to write that. And the third point is that if I bend forward, this will increase. So if it increases on bending forward, again, it's more likely that it's CSF. So this is how I know it's CSF rhinorrhea and it's not just nasal discharge. How do I still confirm? So I check the fluid for beta 2 transferrin levels, right? So if beta 2 transferrin is raised, it's CSF. Most common site, as we saw, is cribriform plate. And what is the best investigation? So here I can do two things, all right? And I'll tell you pros and cons of both. The gold standard or the highest accuracy is CT cysternography. HRCT is the best for fractures. I'll see a bony break like I saw in this case. Now, what if somebody has a lot of fractures? Then how do I know which site is leaking? So that's why what we do is cysternography. I do a lumbar puncture and I put iohexol, iodinated contrast, and I ask the person to lie down in prone position. So all of the contrast from my spinal CSF is going to come down into the nose, and if I see white contrast leaking, I know that's the site. Can you see CSF is now white filled with contrast? So if I see यहाँ से white आ रहा है, I know this is the fracture and this is the site of leakage. So this is the full proof investigation. Only problem, it's invasive, right? So something which is non-invasive is MR cysternography, where I am just doing a heavily T2 weighted image. Do you remember MRCP? I didn't give any contrast. All I had to take was heavily T2 weighted. I know water is white. So if I do a heavily T2 weighted MR, I can actually see the fluid coming out from that site. The only problem, I can't do a bone imaging. I can't see the fracture, right? So both has its pros and cons. CT cysternography is invasive but most accurate. So if they ask you to choose one, I would choose CT cysternography. Okay, but you know now what both mean. Fine, so this is CSF rhinorrhea. Now we talk about the septum. You had a question on this in last year's INA exam. So first of all, what makes the midline nasal septum? So you can see septal cartilage and then two pieces of bone, the ethmoidal plate from up and then vomer, right? So this is what I can see, and this is the sphenoid. Do you remember spheno-vomer joint was Schindler's in anatomy? We had learned Schindler's list. So this is that. So three main parts are vomer, ethmoid and cartilage, but they ask you the smaller part. So that's where I come in and I tell you. So this is rostrum of sphenoid. Nasal spine of frontal bone communicates. You have some nasal bone communicating, and you can also see nasal crest of palatine bone communicating. So other bones which take part would be palatine bone, sphenoid, frontal, nasal bone, right? So that's the small things that matter. All right, so this is what you can see. Now wherever this frontal and the nasal bone are meeting, yeah, so frontonasal suture jahan pe ho raha hai, what is that point called? So that point is called as nasion. All right. So frontonasal is called nasion, and the subcutaneous counterpart of this is glabella. So just above the nasion, where your root of nose begins, you know, external landmark is glabella. And where your nasal bone meets the cartilage, right? Where the nasal bone meets the cartilage is called as rhinion. So remember, glabella bahar hai, inside the bones. So frontonasal is nasion and niche rhinion, bone cartilage junction. All right, so that's what we can see. So you know upper 1/3 is bony and lower 2/3 is cartilage. You can also see here from the external part of nose. So this is the upper 1/3 and this is the lower 2/3 of the nose, made up of two pieces of upper lateral cartilage and two pieces of lower lateral cartilage. So can I say this is the bone part which is called as rhinion, right? So this is about the surface anatomy. So now let's say somebody hit your nasal septum. You can have a septal fracture. So if it is vertical, remember ver, it is Chevrolet's, and if it is horizontal, go ja yahan se, ja, jar jave. All right, so that is jar jave. Don't make mnemonics for both, right? Just remember Chevrolet is vertical fracture in the septal cartilage. You can see that. Yeah, so can you appreciate this is septal cartilage, this perpendicular plate of ethmoid, and this is vomer. Yeah, so cartilage fractures, and how that would present, because it's in the midline, it would have bilateral nasal obstruction, right? So it would present as bilateral nasal obstruction, and if they ask you what is the next step, this is what is a septal hematoma. It's cartilage, right? What did we learn in ear? That if you don't drain hematoma from a cartilage, it will turn into cauliflower ear, boxer's ear, right? There'll be cartilage necrosis. So same thing happens here. I need to drain the hematoma. All right. So plus it will cause nasal obstruction and breathing difficulty. So for both of the reasons, for enabling cartilage to heal and to enable person to breathe, we have to do incision and drainage. Yeah. So super important. Then we talk about somebody fractured the nose, bone, cartilage से आगे bone पे injury हो गई है. So can you appreciate, first of all, this is the nose. I can't see the cartilage on X-ray, right? Once a student had said, "Ma'am, ये पूरा fracture हो गया है." It's not fractured here. It's not seen, right? So if you can feel, upper part is bone and then you can feel soft cartilage. Yeah. So this is the part which is cartilage, not fracture. This is the fracture of nasal bone. So what do I do for a nasal bone fracture is immediate closed reduction. Fine, but if they give you that this patient has edema, in that case we wait for 1 week, right, for the edema to resolve, and then we do a closed reduction. So we reduce the two bony fracture fragments and they'll heal. Yeah. So two forceps for closed reduction. Look for this bend here. Otherwise, they look awfully similar. So where this bend is, Teddy Mansi. Now meet Teddy Ash also. Okay. So this is Ash forceps. जहाँ पे bend है, टेढ़ा. Whereas this is what is Walsham forceps. Okay. So Walsham forceps and Ash forceps may be asked. Then, what is the test that is being shown here where I'm pulling the nasal valve laterally? So this is what is called as Cottle's test. So this is where we're pulling our nasal wall laterally and that increases the space of breathing. And if the person says, yeah, I can actually breathe much better, that means there was narrowing, right? And the most common cause of that is deviated nasal septum. So let's learn DNS, deviated nasal septum. The most common cause of this is some sort of birth injury. Now we talk about Sludder's neuralgia. So this has been an FMG question. So Sludder's neuralgia is where the anterior ethmoidal nerve, is being impinged by, your deviated nasal septum. So imagine this is the nose, right? Normally the nasal septum should be like this, but in this case the nasal septum is like this. So here I have narrowing. So that's where the Quartles test was coming in. But now imagine it's not just a deviated septum, but there is a spur. So now this septal spur is what can impinge on the anterior ethmoidal nerve at the middle meatus, and this is what has been termed as Sludder's neuralgia. How do we manage? First of all, we don't operate till 16 years such that, the nose grows to adult size and then we will operate. Two things, and this was asked in NEET 24. We can either do SMR, submucosal resection, और सेप्टोप्लास्टी. सो सब म्यूकोजल रिसेक्शन को बोलो SMR, MAR. So this is where we have Killian's incision. We are killing it completely. So this is where I am doing a bilateral mucoperiosteal flap raising and correcting it full-fledgedly. The problem with doing anything more aggressively is there's a higher risk of septal perforation, right? Because you're raising bilateral flaps, you are killing the septum. So remember, kill, mar, perforation. Septoplasty is where I'm freeing the septum, Freier's incision, Freier's incision. This is unilateral flap. But the problem with doing something half-heartedly is higher chance of recurrence. Yeah, so high chance of recurrence, Freier. So both has its problems. You choose according to, what is better for the patient. But they have asked this, which has higher perforation? SMR, mar yaad rakho, theek hai, marna, kill. Then we talk about three nose pathologies. So the first one looks like a very woody nose appearance, sclerotic nose. So sclerotic se yaad rakho, this is rhinoscleroma. Yeah, sclerotic nose called as tapir nose, Hebra nose. This is associated with Klebsiella rhinoscleromatosis. So that's no surprise. So they can ask you, what is that bacteria called? Frisch bacillus. This is what are the Russell or the Mikulicz bodies, empty bodies, and because it's an infection treated by fluoroquinolone/aminoglycosides. Another Klebsiella causing something is what is Klebsiella ozani, and what it causes is atrophic rhinitis. All right, so both atrophic rhinitis and rhinoscleroma will have this roomy nasal cavity, but the external appearance is only like this in rhinoscleroma. All right, so here the buzzword is merciful anosmia. The patient will smell very bad, okay, but he himself has anosmia, so he will not know. So that's called merciful anosmia. Klebsiella ozani is also called Perez bacillus. So just like old questions, Frisch and Perez. Bacillus, can you see the roomy nasal cavity, the crusting, and that's what is responsible for the bad smell that they emanate. All right, and the management. So management one could be just nasal douching. You want to clear out all of these secretions. So that is done by an alkaline solution made up of NaCl plus sodium bicarb plus sodium biborate. Okay, I don't know the chemical formula for biborate, so I'm going to write it. So sodium biborate, and the ratio is 2 is to 1 is to 1, right? So you can do this. If it doesn't work, there are some antibiotic solutions as well which are available to clean it. But the question they tend to ask is modified Young's surgery, where they try and make this nasal cavity, smaller. Yeah. Another thing which is being done now is Lawton-Slager procedure, where they put a submucous Teflon, right? So again, Teflon will expand. So submucous Teflon will cause this nasal cavity to become smaller. Okay, so that's what you can do. Then we talk about the other nose, where it looks like a mulberry or a strawberry nose, right? So mulberry nose, strawberry nose. This history would have been of a swimmer. So this is what is rhinosporidiosis. Okay, so rhinosporidiosis, we thought that, oh, on histology, we found that there are these sporangiums with endospores, right? So looking at that, we thought it's a fungus, but it did not have the elements of fungal cell wall. So, they don't really know what this is, an overlap between fungus parasite, not that it matters. But just remember, histopath is sporangium with endospores, and the treatment is just excise and give dapsone. Wherever nothing else works, dapsone somehow works. Yeah, so that's rhinosporidiosis. Then you have this hypertrophy of sebaceous glands called as rhinophyma. Yeah, so this is what is called as a hot potato nose. So this is where you have sebaceous gland hypertrophy, and this is one of the complications associated with rosacea, right? So rosacea on, aggressive mode is rhinophyma. What we are seeing here, this picture has been asked. This is what is septal perforation. Can you see one of the perforations happening from the nasal septum? So this is where, if asked treatment of septal perforation, it is a septal button. You will put a septal button. You will not leave it, right? Because it will not heal otherwise. So you want to remember, TB, sarcoid, SLE, leprosy are all causes which can affect bony or cartilaginous part of the septum. Cocaine, syphilis, Wegener's. ये part काट दो last. So what are causes of septal perforation? Any of your granulomatous disorder like TB, sarcoid, leprosy, lupus can cause this. Cocaine, yeah, because you snort cocaine. Syphilis and Wegener's, right? So all granulomatous disease essentially can cause involvement of nasal septum. Very important. Vasomotor rhinitis is where there is parasympathetic overactivity, right? Where you have persistent nasal discharge. So high parasympathetic discharge. One of the DDs for the same is allergic rhinitis, where there's a component of allergy. The only difference is in vasomotor rhinitis, everything else is normal. No atopy, no other allergy, eosinophil, count is normal. Whereas in allergic rhinitis, some of those predispositions would be there. So that's how you can distinguish. So for allergic rhinitis, few things have been described. In fact, if you look at me closely, you can see these. So this is where, if you look at the patient, they'll have dark circles which are called as allergic shiners. They'll have these eye folds, creases, which are called as Denny Morgan folds. They'll keep doing this. This is called as allergic salute. Yeah, so all of these things would be present here. All right, for vasomotor rhinitis, so initially you can try topical steroids. Okay, but if it doesn't work, one of the things I taught you in anat, in the Vidian canal, we have the GSPN, right? So we go and block that. We do a Vidian neurectomy, which would block the GSPN and DPN. That's the Vidian nerve. So great superficial petrosal nerve is what supplies lacrimation and the nasal mucosa. So we're just blocking the parasympathetic stimulation. Rhinitis medicamentosa, as the name suggests, it's because of prolonged usage of your nasal decongestants. So what nasal decongestants are alpha agonists, right? So they are vasoconstrictors. But what happens if you use them on a prolonged basis is, what happens is they show a rebound vasodilation, right? So they show opposite action now, rebound vasodilation, and the only treatment is stop using them and their effect will be back, right? So just stop the usage. So this is about some rhinitis now. Now we talk about very important, very basic concept of epistaxis. So epistaxis, you all know this is the Kisselbach's plexus that diagram is showing, and this is the most common cause of anterior epistaxis in children, right? So the most common cause of anterior epistaxis is trauma because of nose picking in children, right? So this is what happens, and the area from where they bleed is called as Little's area in the Kisselbach's plexus. So let's talk about this. So this is essentially the Little's area. Okay, so what forms the Little's area is the question that they ask. So we have anterior ethmoid, facial, greater palatine, lesser palatine, and the main artery. If somebody will ask you what is the artery of epistaxis, this is phenopalatine, the branch from third part of maxillary artery, right? All of these palatine are third part. So this is what we need to know. So all except posterior ethmoid, not part of Little's area because it's posterior, right? Another question can be, which is the only part of internal carotid artery which is forming Little's area? Then answer becomes anterior ethmoidal, right? So this is about the vascularity. The vein that can lead to anterior epistaxis, usually that bleeds in adults, is going to be your retrocolumellar vein. So that's the vein of the anterior nose. So retrocolumellar vein is what can bleed in adults when it is anterior, remember. If there is posterior epistaxis, the cause is usually a venous plexus called as Woodruff's plexus. So Woodruff's venous plexus is what is the most common cause of bleeding in posterior epistaxis, and the risk factor here is hypertension. So this is what happens in adults, right? Hypertension, posterior epistaxis. Okay, how do we manage? So in any anterior epistaxis, that's the most common one, so we learn the management of that is you have to do the Trotter's maneuver. You all know the Trotter's maneuver. I'm pretty sure everybody here would have had epistaxis once in your life. So you pinch the nose and you sit up, leaning forward, and you don't swallow the blood is what we tell the child. So Trotter's maneuver is what is done, and it's effective in almost 80 to 90% of the cases. That's all we need to do. But if that doesn't stop the bleeding, in that case we have two options. So if you have somebody who can do a cautery, endoscopic cautery, that's the best step. So that is preferred if it's there in the option. So endoscopic cautery is what is preferred. But if let's say you are in a peripheral setup, there's no endoscopic cautery available, in that case we would do a nasal packing. Yeah, anterior nasal packing to stop the bleeding. If both of these interventions are not helping, then what do we do? Then I have to go for endoscopic ligation, which is called as TELSPA. What is TELSPA? So that is transpalatine. So coming from the palatine root, endoscopic ligation of the artery of epistaxis, whose phenopalatine artery. So that's what you target. If this doesn't stop, we'll go and target maxillary, right? Maxillary artery, so that more branches can be occluded. But this is what we remember here for management. Next, we talk about a few infections of the head and neck. Some overlap with pediatrics and micro here. So what is this? Is a floor of mouth infection. It's a gross misnomer. The name is Ludwig's angina. Okay, so imagine this uncle's name is Ludwig. Ludwig uncle did not have chest pain. He came that I'm having this floor of mouth infection. He said, no, but uncle, someday you'll have angina. So we named it Ludwig's angina. Okay, so this is what is a floor of mouth polymicrobial infection, and that's all you need to know. And this is called as double tongue appearance. It looks like Ludwig uncle has two tongues. Okay, so that's Ludwig's angina. From Ludwig's angina, we go to another uncle whose name is Vincent. Vincent's angina. Again, Vincent also didn't have chest pain. In fact, Vincent was a prisoner of war and he was living in a trench for a very long time. So this is called as trench mouth. Yeah, in people who have very poor dental hygiene, like prisoners, right? They would not be giving a good toothpaste, I assume. So poor dental hygiene is what is one of the risk factors, and that's why this is also called as, it's called as acute necrotizing ulcerative gingivostomatitis. Okay, so this is what we are seeing here. Fine. So ANUG, anug. Okay, so they've given it three names: Vincent's angina, trench mouth, acute necrotizing ulcerative gingivitis, where you can see all of these membranes, right? So this is also a polymicrobial infection and it's associated with one fusobacterium and treponema species. Okay, so treponema, not pallidum, fine, not the syphilis treponema, but the other treponemes. Fine, so this is Vincent's angina. Next, X-ray diagnosis, very easy. What do you see here? Can you see a thumb-like projection happening here? This is the level of the epiglottis. So always look out for the hyoid bone on the X-ray. When you see a swelling here, this is acute epiglottitis. So is this a bacterial or a viral infection? It's a bacterial infection and it's a severe one. Why? Because the child here is going to be very sick. The child is going to have fever, may run a very high fever with sepsis like symptoms and won't be able to breathe. Dyspnea ho raha hai because the airway is blocked, can't swallow because the airway and the esophagus is blocked. So there's drooling of saliva. They will give you this hot potato voice, can't speak properly. And what is very important, they might give you tripod position. Child is sitting facing forward जिससे उसको breathing better हो जाए. So that's tripod position. What do you do here? So my first priority is airway protection, right? So I need to protect the airway. If that means